All right, good afternoon and welcome back to the Plus course. So this is module 2. Zara is doing well. Thank you so much. Yeah, feels after very long. So I'm sorry that I had to reschedule yesterday and we have to meet at 2 o'clock in the afternoon, which I'm sure is not a very good time for all of you. But the good thing is we can complete ortho in one day. Yeah, so we'll have 4 hours of classes and we'll finish off one subject. So that means one more subject is added to the list of your subjects that you all have to revise. So I hope module 1 we're all done with, है ना? कि module 1 में there needs to be no doubt. And see PDF Shrikant is there on the group which is linked. So the pinned link, you can just click on it. It will be redirected to Telegram and there you'll find the PDF. Okay, so there every day I'll post the PDF. So a few of you might still be new plus members, so you can just add this. No, this is going to be 2 hours from now till February. All of the classes are going to be 2 hours each. Okay, not 1.5 hours. Okay. Yeah, I missed you guys too, and hopefully we'll be able to cover all the subjects now. Zaru is better now. Actually, yesterday my babysitter was also on leave, so I did not have any help to look after her, so I had no option but to reschedule. So yeah, let's. Audio is okay. Ashutosh, just refresh. I think it should be okay. ठीक है, so try and finish off the subjects of module 1 if you're still not done. Okay, तो खत्म करते जाओ साथ साथ में. It's not like they need to be over. You have to keep them together. Like I keep saying, constantly keep revisiting them, keep revising the PDFs, है ना? Yeah, for sure. This for everybody. So orthopedics, important stuff, all the exams. Yeah. ठीक है, सो शुरू करें. या मुझे भी अधूरा सा लग रहा था, बट फ्रैंकली स्पीकिंग आई हैड नो टाइम ओनली टू फील अधूरा. I was taking back-to-back offline classes when I was not taking these, so I actually had zero time. Whatever time I have left is for Zara, and that way my day ऐसे जाते हैं कि पता ही नहीं चलता. Yeah. FMG I'm gonna give it on Saturday. Yeah. Tomorrow I'm going to Bombay for cerebellum class, and then after coming back on Saturday I will take. Okay, ठीक है. Audio is breaking on and off, is it? No problem for my end. Shrikant, there is a link on. सबसे ऊपर देखो, there's a pinned message. Click on that. You can join Telegram group. It's not lagging, right? It's okay. ठीक है, फिर शुरू करते हैं. कोलकाता I'm coming on 5th and 6th November for neuros. Okay, chalo fir shuru karte. Okay, no chatting about other things. Yes, something very important which I have forgotten and I almost remembered is about the combat quiz. So all of you guys, please give the combat quiz. Depending on what year you are in, there are going to be 5 different quizzes, okay, which are going to be held. So register for your year, and there are some really cool prizes. If you win, you get subscription to आप लोगों के पास anyways है, but you will get a laptop, an iPad, and smartwatch and whatnot. So you'll get a lot of prizes. So I'm sure that everybody likes prizes. So do attempt it. It's a 1 hour quiz. I'm just gonna send you the link. Yeah, everybody can attempt. Why would plus members not be allowed to attempt? Obviously you can attempt. Okay, so I'll just share that link also. In case you've not enrolled, you can enroll into it. I don't think they'll ask for a code for you guys. In case they do, my code. It's ZVORA. You can just write that. I'm just gonna share the link, just deriving it from the chat. Okay, so how we're gonna do ortho? So I've covered everything from ortho in these 2 classes. Okay, so we have 4 hours, so that's good enough time to complete ortho. So in the first half, we'll be talking predominantly about the tests, trauma, and splints and casts, nerve injuries. That's gonna be, the quiz is gonna be on 16th of October, 12 p.m. Okay, 12 p.m. हाँ, इतना enough है. Just follow it up with MCQs. Now I have not included PYQs because I thought कि PYQs ना हम लोग as special class quiz ही कर लेंगे like we did last time, because in so much rush then content gets left out. So I thought that we'll just do them as special classes simultaneously, है ना? तो वो PYQs हम separate ही कर देंगे, and here we'll do content, right? So that's what we'll do. Yeah, फटाफट से rapid fire quiz कर लेंगे, 2 subjects each कर करके we'll do as special class. Okay, so that is the plan. I'm just, my WhatsApp is not loading only. I'm just going to share the link. है ना? Radio PYQ is left. कर लेंगे रेडियो रेडियो ढूंढिए मेरी इज्जत ओनली फॉर सम रीजन लाइक आई एम नॉट serious about radiology only. I'll do it on 21st. We have a 4-hour crash course, no, in that I'll include all of the previous year questions. ठीक है, उसमें सारा कुछ कर लेंगे 4 hours में. ठीक है, हाँ 21st को रेडियो के लिए रिजर्व करके रखना. And then you know the schedule, no? For this 1 month module, we're going to do ortho, psyche and anesthesia lined up next. Then we have micro 2 classes and we have obs gynae 2 classes. Link expired आ रही है, इतना जल्दी expire कैसे हो गई? Wait, I'll just post again. Before that, I just want to share the link with you guys, okay? For the combat, so that even if you've not registered, you can do it right away. Okay, yeah, do that. Come on. Now I'm pinning this also. I don't think I can pin more than one message. I'm pinning this. Baki, whoever could not join the link, no, you can just message me and I'll add you to the group. ठीक है, अब start करते हैं, है ना? Yeah, do only off-thal PYQs because I'm also not a big fan. Just do PYQs for subjects that you hate, you know, and just do the most important topics. 5 classes emergency trauma. Was trauma covered there? If trauma was covered, no need to do it again. Otherwise, you can do it from RFS. हाँ चलो फिर शुरू करते हैं. चलो हाँ फिर नहीं करने की जरूरत. We'll start off with the test because recently we have seen that in every exam you get 1 odd question from these tests. Okay, so we're starting off with all of the important tests that you need to know about. All right, quickly tell me what is the first thing that you are seeing here. इसमें क्या दिख रहा है? What is this first test? 3 bags जो आपको दिख रहे हैं in black and white. Correct. This is not just Schober. This is modified Schober's test, right? So this is called as modified Schober's test. Where what we are gonna do is, so we are taking a measuring tape, and this is done for what? Modified Schober test is done for a flexion deformity in ankylosing spondylitis, right? So angspond, the pen is also causing some sort of problems. So in angspond also, remember, you're gonna have flexion deformity, right? The complete spine is fused like a bamboo spine. So there is flexion deformity, which is noted. Correct. So what we see is basically, I'm going to keep the baseline here. These are called dimple of Venus. Dimpling sign nahi hai. These are normal physiological dimples of Venus which people have, and they basically mark the PSIS, posterior superior iliac spine. तो उसको mark कर देते हैं. So this is our baseline, and then I calculate a distance of 10 centimeters at the top. This is my baseline marking. When the person bends, this distance has to increase to 5 centimeters more. Correct. So this is gonna be 15 centimeters or more in normal person. In persons who have a flexion deformity, we are going to see that this is reduced. Okay, so it marks basically that there is a fixed flexion deformity that we are seeing when the distance is less than 5 centimeters increased upon flexion because their spine is completely fused, so they can't flex. ठीक है, तो ये है अपना dimples of Venus. Okay, not very important. So this is a modified Schober. All of these will come as image based question. Either video या GIF देंगे or they'll give image. So we have to be very quick and efficient. बस image देखा, आंसर क्या है, that's it, है ना? हम अपने को पूरा प्रोसेस की कोई जरूरत ही नहीं है. Okay, so this is gonna be angspond. What is this? When you ask the person to bend and this lateral curvature of spine either resolves or it remains. Correct. So this is called as Adams forward bending test. So this is used as a screening test for scoliosis. When we want to basically see if the scoliosis is actually just postural or scoliosis is structural, है ना? Real scoliosis है या फिर खाली posture के कारण है. So if it corrects, if I see that on bending it has corrected, then it is postural. I'm writing P on, right? So this is postural, and when it remains, so this is structural. All right, so this is going to be structural scoliosis. Okay, so this is called as Adams forward bending test. All right, so this is going to be Adams forward bending test. ठीक है, cool. So this is going to be scoliosis. Got it? So just identification of test, and then we basically move ahead. What is this? ये तो सबसे cliche, सबने करा है. Before doing any ABG sampling, we have to perform this test, right? So this is for integrity of the palmar arch. So this is called as Allen's, and again this is basically modified Allen's test, wherein what I am doing, पहले दोनों बंद कर दिया, white हो जाएगा. Then when I open radial artery, it will again become pink. Then I open ulnar artery, it will again become pink. So basically I'm testing the patency of the palmar arch, right? So this is done as a prerequisite to any ABG. It's clinically very important. So all of these tests, you know, you need to have down. ये गलत नहीं कर सकते. Okay, so these are the 3 most important tests. All of these 3 tests are for the bundle of what? Yeah, these are all for bundle of thoracic outlet syndrome. So So for thoracic outlet syndrome, remember we can have either a cervical rib or a tumor or any sort of a obstruction which is causing obstruction at the thoracic outlet. The obstruction per se, what is the most common structure to be obstructed? Nerves, artery or vein? So the order is nerves, neurogenic compression more than veins, followed by artery. So subclavian artery, subclavian vein first, followed by subclavian artery. And so remember, uh, in nerves you will have T8. No, sorry, what are the nerves which are involved? Don't ask me to repeat stuff. No, you can see the recorded version, otherwise we won't finish. Isliye, hai na? So what are the nerves which are most commonly obstructed? Which roots? Yeah, so it's the C8 and T1 nerve roots which are most commonly involved here in thoracic outlet syndrome. Okay, so there are three tests. This has come as a repeat question. So what is this? The most common one. This is the Roos test, or it is also called as EAST, extended arm stress test. यहाँ पे हमने arm को extend करके से 5 minutes तक we are telling the patient keep doing this for 5 minutes and extend arm करके keep doing this for 5 minutes. And if you have basically signs of obstruction, you will have either paresthesias or you will have claudication. Okay, so this is the Roos test. What is this? What is this that you are doing here? What is this that we are seeing? This is the Adson's test, right? So this is Adson's, जिसमें मैंने arm को hyper extend करके external rotate करा, and then I'm basically palpating the radial artery. If the radial artery, remember, is blocked, we ask the patient to take a deep inspiration. Deep inspiration पे अगर block हो गया, that is the Adson test. So just see the picture, they'll ask you to identify. And what is this that you are seeing here? When the arm is abducted, hyper extended, and then you are seeing the radial artery pulse, yes, it is right. So remember raw, hai na? So in this order you can just have this visual memory. And again guys, keep revising the PDFs. Even for the first module, once you revise these PDFs enough, no, visual memory ho jayega. Jaise acha upar ye dabba tha, niche ye dabba tha, you'll remember. So that's how, you know, I have kept so many images so that we can remember. So remember raw, 3 tests for thoracic outlet syndrome: Roos test, Adson test, Wright test. ठीक है, तो ये हो गए हमारे thoracic outlet. Few more tests. What is this? When you have an Achilles tendon tear and you are pressing on the calf of the person, what is this test called? This test is called Thomas test. Is it called Thomas test or is it called Thompson test? It's called Thompson. So not to be confused with Thomas test that you've just done. It is the Thompson test. Okay. Thomas just uske saath mein, which is very, very important. So Thompson test is actually for tendo Achilles. Can I just write Achilles tendon 80? So this for Achilles tendon tear. So what will happen in all of us who have normal Achilles tendon? मैंने calf को compress किए. I press on the calf. What will happen? Our sole will move. It will move ahead, right? On the other hand, जिसका Achilles tendon is torn, this calf will not move. Okay. So this is the Thompson test for Achilles tendon tear. One more word about Achilles tendon. The classification is called Kuvada classification. Correct. So the classification of Achilles tendon is called Kuvada. I have all of these compiled in one places. We'll note that down, but abhi se yaad rakh lo, Kuvada. On the other hand, favorite of your examiners in the recent time, this is Thomas. है ना? So Thomas test हम क्यों करते हैं? We do it for flexion deformity, right, of the spine. So basically iliopsoas का deformity देखना है, fixation, contracture देखना है, fixed flexion deformity देखना है. I will do this. So this is basically, thank you, fixed flexion deformity or for iliopsoas contracture basically. So what I'm going to do is I am making this person lie down. हाँ, इसके steps मुझे बता रही हूँ. So we make the patient lie down. We ask this person कि इस knee को chest पे लाओ. So what will happen in normal person? This knee should stay as it is. In normal people, we will see that this also gets abducted, right? We'll see that this gets flexed and abducted basically, this knee also. Or sometimes it can also happen that there is exaggerated lumbar lordosis. So exaggerated lumbar lordosis in itself is a sign of iliopsoas contracture. If ye nahi hai, only then I will do the test. So the first step is to test for exaggerated lumbar lordosis. After that, we will do this test where I ask this person to place the knee towards the chest and I will see that there is abduction. Let me see if I can share my screen because it's so important. I just wanted to show you a video. Can I do that? Would you like to just see this because it's so important? Yeah, I'll just show you. Okay, can you all see YouTube? Huh? I think you can, hai na? I'll just show you this video here. So see how this person is doing this flexion.
And ask him if he can feel a stretch in the right groin. With a positive test, you will see that the extended leg is lifting off the table, like in this case.
Yeah,
you can even measure the angle at the knee as a reference. Okay. If the extended leg is not lifting off the table, but is abducting, we are talking about the so-called J sign or stroke, which is indicative for a tight iliotibial band. All right, guys, this was the video on the Thomas test.
Got it? So basically, we don't want to worry about iliotibial at the moment. We just want to worry if the knee अगर ऊपर आ गया है ना. So Thompson का interpretation या Thomas का भी जीत. So here it's just that अगर ये ऊपर आ गया, if knee is हाँ उसका positive था, if knee is lifted off, that means that fixed flexion deformity है. So Thomas में है कि अगर पैर ऊपर आया, like in our video, that person has an iliopsoas contracture. Okay. On the other hand, Thompson में ये है आपने calf को squeeze करा and if the pair moves, if the sole moves, that is normal. If the sole doesn't move, flick nahi hua sole with compression. If this is calf, suppose, and this is my pair, if I squeeze here, this will move, right? ऐसे हो जाएगा. And if it doesn't move, then it is negative. All right. I mean, it's 80 tear. Okay. So this is about the two tests. What is this? How to find iliopsoas? By this only, fixed flexion. Okay. They also have squaring of pelvis also as a step. Just see that question, just send that question on the group, we'll see and I will figure it out. Okay, but abhi to pehchan lo khali, so this is Thomas test. Okay, let's not waste a lot of time. Okay, tell me this, what is this? Yeah, this is straight leg raise test, also called as Lazag test, right? So this is also called as Lazag test, wherein I am asked the patient to straighten the leg and between 30 to 75, this is key, between 30 to 75 degree of raising, if there is paresthesias, that indicates that there is nerve root compression. And nerve root compression ka most common cause kya hai? Where do we do this clinically most commonly? Something which is very common. If you see any MRI center, most common MRI is done for this. Correct. It is for disc prolapse or PIVD, right? So for disc prolapse, again, you can get independent question. So investigation of choice for disc prolapse is going to be MRI, right? So on MRI, remember the normal disc should be white. Do you see how they are white in the center because of the nucleus pulposus having water? It should be white. When the disc is degenerated, that whiteness will be gone. Can you see here what level is this, guys? So again, very easy. Jahan pe bend aega, this is S1, this is L5, this is L4. So one, I can see that the disc is dry. We call it disc desiccation. Pani nahi hai, white nahi, hyper intense nahi hai. And then can you see one disc is bulging outwards? So there is herniation, right? There's posterior herniation of disc. The question is, at this level, they'll give you this MR and they'll ask, what is the nerve which is most likely to be compressed in this person? So we see that, okay, L4, L5. So I want you to write in the exam that, okay, this is the level and don't jump. Always start from S1. S1 se dekha, L4, L5 disc hai. What is the most likely route to be compressed? Correct. It is going to be L5, which is most commonly compressed. So can both be compressed? Yes, both can be compressed. So it will depend on what kind of a disc herniation I have. So for that, I have this schematic. Anytime we have a disc, in the center, I have these nerve roots which are called traversing nerve roots, है ना? Traversing nerve roots. And जो बाहर nerve root निकलता है at every level, that is called as the exiting nerve root. Okay, so exiting nerve root is the ऊपर का level, which is L4. Traversing nerve roots is the नीचे का level, which is L5. S1, how to identify is on the basis of this. No, sacrum, you will see a bend. So the moment you see a bend, this is S1, sacral promontory. And उसके ऊपर, ठीक है? Little clear, please. Handwriting, is it not clear at all, or my explanation is not clear? What is not clear? Handwriting I can improve, explanation probably I can't. Okay, so traversing is L5. Okay, so traversing is L5, wherein we basically have the disc. Okay, we have the disc basically which is going, and this is theek hai, chalo. So this is the disc which most commonly herniates here, है ना? So most commonly disc is going to herniate पीछे, such that the traversing nerve roots are going to be compressed more. Okay, so this is the most common thing to be compressed. अगर पूछते हैं क्या दोनों हो सकता है? हो सकता है. If you have a very severe disc, even the exiting can get compressed. Or if they ask you if central, as Arjun is correctly saying, if central herniation hai, what will get compressed? L5. If lateral herniation hai, or correct, there is ligamentum flavum hypertrophy, or there is lateral compression, then what do you have? Then you have exiting root. Okay, is this clear, everyone? So this is about the thing. Okay, So this is about the various nerve roots herniation that we're going to have at different levels. Is this clear to everybody? So this is slightly difficult and confused. So I hope this is clear. Overall, most common compression is this only. So L4, L5 most common disc hota hai, and L5 nerve root is most commonly compressed at this level. Okay. So now going on to few more tests. So these are not very, very important. These are tests for sacroiliitis. So what do you see here? Whenever you see कि 4 ban raha hai, this is called as figure of 4. Whenever you see a figure of 4, what is this test called? This is Patrick test. Okay, so this is called as Patrick test, which is the figure of 4 test. And the other test, when you are again just like Thomas, इसको आप ऊपर ले रहे हो and then this goes down. All right, this goes down. What is this test called? This test is called as Ganslin's test. So both of these tests are used for sacroiliitis. All right, so these are used for sacroiliitis. In this, you will pull this to chest and you will push this other knee downwards. Okay, so these are two tests which are done for sacroiliitis. Patrick is commonly for unilateral sacroiliitis. Ganslin's is for bilateral sacroiliitis. You can just have this mental picture in your mind. Very, very important. When you see person is lateral, the moment you see कि बंदा side में लेटा हुआ है, lateral decubitus में लेटा है, only one thing should come to your mind, which is Ober's test. Okay. So Ober's test, we will see that the person is on the lateral position. And this is done for what? This is done for iliotibial contracture, right? Not for cerebral palsy person, it's also iliotibial contracture, which could be seen in poliomyelitis also. So any sort of myopathies basically, or any cause of iliotibial contracture, we will see this. And this is basically a test of abduction contracture. That is also something you can remember, that this is for abduction contracture. Okay. Sacroiliitis wala Angst-Pond mein? Yes, yes. So sacroiliitis is something which is the earliest finding of Angst-Pond, right? So these are clinical findings which can be seen in Angst-Pond. Apart from that, sacroiliitis can be something which can be seen for TB also. Okay. No, इसमें इतना नहीं जानना कि क्या टेस्ट के steps and positive. Just remember images. Only images are important. They'll ask you to label the test. These as it is, these are not very, very commonly asked. So बस ना इतना ही पहचान लोगे बहुत है. Okay, so this is about that. Then 3 more tests now for the upper limb. Yeah, unilateral sacroiliitis TB, bilateral Angst-Pond. Okay, very nice. What is this? This is called as when you see कि thumb नीचे, you are pouring down the cans, है ना, thumbs up layer उसको नीचे pour कर रहे हो. So thumbs up का can will become empty. So this is your sign to pick up empty can test. Empty can test is done for which condition, which muscle? No, this is not subscapular. This is supraspinatus, right? So this is supra. दोनों को confuse नहीं करना. This is for supraspinatus, है ना? Can ऐसे याद रखो नीचे कर रहे हैं, but test is supraspinatus. Okay, so ulta. Here, what we are basically doing is we are resisting the downward motion. And again, what happens here? आपने arm को नीचे करा and then it basically goes down. ये क्या है? This is called as not lift off. This is drop off. So this is called as Codman's drop arm test. Okay, so this is Codman's drop arm test. This is the third place where we are talking about Codman. Where are the two other places जहाँ पे Codman आएगा? One is Codman's tumor, which is chondroblastoma. One is Codman's triangle, which is seen in osteosarcoma. Homework करके आए हैं सब? Advanced homework who has done? Who are the good kids who have done advanced homework and come bone tumors? Yes, very good. Okay, so दोनों की बात करी थी. So the Codman's drop arm test, which is also for supraspinatus, is also for supraspinatus muscle. Okay. On the other hand, when you see this कि arm को lift off कर रहे, correct? This is the Gerber's lift off test. This is done for subscapularis. Okay, so this is done for subscapularis and CB is chondroblastoma. Okay, chondroblastoma. So subscapularis, and this is what? This is forgotten tendon of the rotator cuff, है ना? इसको सब forgotten tendon बोलते हैं. SSP supraspinatus. ठीक है? So this is subscapularis forgotten tendon. धीरे धीरे you will get used to all my handwriting and my short forms and everything. If it is your first day today, just have faith and stay patient. सब कुछ समझ आ जाएगा, है ना? बाकी सब pro हो गए हैं. In 1 month only lots of people have become pro. You will also get pro in just some time. Okay, चलो. Going ahead, what do we have? This फिर आप मेरे ही PDF. You will not need Regina Phalange also. You will understand my PDF only in some time. What is this? Yeah, these are all tests for carpal tunnel syndrome. Very, very important. Carpal tunnel median nerve compression. What do we have here? This is one which is done most commonly. श्रीकांत को क्यों नहीं मिल रहा PDF? Just hold on, no, I will send you towards the end. Just attend class now, don't worry about PDF. अब क्या करोगे? ठीक है, तो अभी क्लास में ध्यान दो. Phalen's test, right? So Phalen's test is what you are having. Then here where you have a direct provocation, you're directly compressing on the nerve. This is Durkin, and this is what? This is the most specific test, isn't it? So this is repeat INI CT question कि बताओ most specific क्या है, because इसमें तो nerve को ही आप tingle कर रहे हो, isn't it? So you have, all of these are provocative tests, and this is the one which is most specific क्योंकि nerve ही दबा रहे हैं. And when you are tapping on the nerve, terse tingle. So this is the tingle test, which is basically done for nerve injuries, right? So this we'll talk about again also, but this is something which we can do for all nerves. Okay, so we just tap to see where the nerve currently is getting compressed at. All right, so these are the three tests that can be asked as very, very important, very common image based questions for carpal tunnel syndrome. Very, very important. All of these tests are for what group? We are now talking about DDH, developmental dysplasia of hip. So when you measure दोनों का knee flex करके you're measuring, you are seeing unequal knee heights. This is called as Galazzi or Alice's test. Okay, so this is called as Galazzi or Alice's test. Similarly, इसी में when you see कि gluteal height unequal है, gluteal height unequal है, what test that is? Anybody can tell me what is the name of that? Correct. This is called as Klissic test. Very nice, Britati. So this is the Klissic test wherein you see that the gluteal height is abnormal. Gluteal folds का height is abnormal. Knee का देख रहे हैं तो that is basically Galazzi or Alice's. What is this? जब मैं देखूं कि knee is the hip is basically telescoping into the hip joint. This is called telescoping positive. So when you will basically flex the knee and you see कि नीचे telescope हो रहा है hip joint, that is telescoping sign. When you try to feel the femoral pulses, but you can't because femoral pulses are pressed against the femoral head. Here the femoral head is roaming somewhere because of DDH. So this is called as vascular sign of Narath, basically where you will not be able to palpate the femoral pulses. Okay, thank you so much. And what do we have here? The two most favorite signs जो हम बचपन से पढ़ रहे हैं, बच्चों के बचपन से पढ़ते हुए, Barlow and Ortolani. Now here this is one very good example where a mnemonic has messed up a lot of answers for people. Okay, where we know Barlow is Baharlo, right? So when we say Baharlo, people think that we are abducting, but we are not abducting. Okay, so you need to remember that it's a bad mnemonic. ठीक है, याद रखोगे कि it's a bad mnemonic. बहुत लोगों ने गलत करा इससे. So we will remember Barlow is basically adduction. So we are adducting and उससे क्या हो रहा है? बाहर हो रहा है, बाहर हो रहा है. So that is going to be dislocation. So it's a bad test. We are dislocating, right? So you just remember it's a bad mnemonic. It's a bad test. हम adduct कर रहे हैं और उससे dislocation हो गया किसी का. On the other hand, Ortolani is very good. The moment I abduct, opposite ही हो गया. I just have to remember bad. When I abduct, what will happen? Abduction, it will relocate. Yeah. English only. Baharlo is Hindi. No, that's the mnemonic. What can I do? So you don't remember Baharlo. Forget it, Sabreen. You have to remember. So very good for you. This is one very good place where if you don't know Hindi, you are in a very good place because your mnemonic is only bad. You don't need to worry about Baharlo. You remember bad. So bad is what? You are bad, so you will dislocate. है ना? So B means Barlow means adduction, and when you adduct, the knee will get dislocated. बाकी Hindi वाले will be Baharlo, they will abduct, and they will get confused, but you will not get confused. Okay, understood? So this is Barlow and Ortolani. Fine, understood. So these are the two tests of, these are all the tests of DDH per se. Okay, going ahead, what is this very, very favorite? You are basically doing what? Yeah, so this is Finkelstein test. This is done for what condition? This is done for De Quervain's tenosynovitis. So can you tell me De Quervain's tenosynovitis, what are the joints which are affected? Yeah, so there are gonna be, ye again, ye confuse mat karo, ABPL and XPB, right? So this is going to be abductor pollicis longus, extensor pollicis brevis, right? So these are the muscles which are affected here. These are going to be your lateral most boundaries of your anatomical snuff box. Okay, telescoping sign, any eponym? नहीं, इसका pneumonic I have, but it's again in Hindi and it's not very good. I mean, it's not a very good pneumonic which I have. I somehow just remember this in one flow. So how I have remembered is sometimes when you have a breakup, okay, right? So I'll tell you, when you have a breakup, तो हम क्या बोलेंगे that your ex is also drinking. तो ये हिंदी में, ठीक है, I can't help it. So X is also drinking. Pina means drinking, so we have to say that X भी पी रही है, right? So X भी पी रही है, अब तू पी ले, like that. So अब पी ले XPB. So that is the mnemonic, okay, which I had somehow it fell into place. All right. So will you remember? I'm sorry, Sabrine, but अब पी ले XPB. Okay. So that is what you have to remember. Finkelstein's, B. Quirian, tenosynovitis. ठीक है. Toppers do this. Toppers do make mnemonic like this. Toppers don't do this. Okay. तो ये है. चलो. अब बताओ. Next, what is this? Sachin Tendulkar. Sachin. Tennis elbow. What is this test called? So tennis elbow is what? Lateral or medial epicondylitis? Tennis elbow is lateral epicondylitis, right? So what is the tendon group that is going to be affected? It's going to be the extensor tendon. So I'm doing a forced wrist extension and I will keep my finger here and you will have pain, isn't it? So on wrist extension, when you have pain, this test is called Cozen's test. Okay, this is Cozen's test of tennis elbow lateral epicondylitis, and for this only we give a brace. अगर यहाँ पे brace दिख रहा है, this is counter force brace. Okay, tennis and golfers, why? I mean, इसका तो mnemonic भी नहीं. So tennis elbow is lateral and golfers is medial. IMG, do you know international medical graduates or Indian medical graduates? You can just remember medial epicondylitis and golfers. ठीक है, works. General medicine, हाँ, general medicine याद रख लो. IMGs याद रख लो. ठीक है, all right. अब बताओ, what is this? Now we are going on to the meniscal and ligamentous injuries. So this is Latchman test. Is this drawer or Latchman? This is Latchman test. Okay, so when you see that the angle is 30 degrees, so Latchman is 20 to 30. Most places it's 30 is what is acceptable. Somewhere it's written 20 also. Right? So it's okay. 20 to 40 hota hai basically. So Latchman is 30 degrees where you are basically pulling anteriorly. So आगे pull करोगे and you have anterior tibial translation. That is a sign of ACL injury. On the other hand, anterior drawer test is going to be at what degrees of flexion? That's going to be at 90 degrees, correct? So that's going to be 90 degree. Again, same thing. When you anteriorly pull it, there is ACL injury. There will be anterior tibial translation. On the other hand, all three of these are your meniscal injury tears, isn't it? So here the mnemonic is when you see one person is dancing on one limb. Do you know thalaiva? थलाइवा है ना, तो थलाइवा से याद रखो डांस. ओके, सो दिस इज थेसली टेस्ट. ओके, सो थेसली टेस्ट, थलाइवा टेस्ट, दिस इज व्हेन यू आर डांसिंग ऑन वन लिम्ब. ओके, सो बेसिकली इट्स रोटेशनल. मेनिस्कल इज रोटेशनल इंजरी, isn't it? So rotational injury टेस्ट करे, you will have tenderness, थेसली टेस्ट. On the other hand, when the person is prone और आप पीछे ना डाल रहे हो, so here the mnemonic is एप्पल को ग्राइंड करने के लिए हमें उल्टा जाना पड़ेगा. ऑलराइट, सो दिस इज Apley's grinding test. Okay, so Apley's grinding test. On the other hand, the last one where you are just basically flexing and you are doing rotational stability, this is McMurray. This is McMurray's test. So there are three tests for meniscal injuries. So just I have noted them down. Anterior draw 90 degrees, Latchman 30 degrees, PCL same thing, posterior draw and posterior sag test are not very important. Okay. On the other hand, two injuries again, valgus stress. When I'm doing a lateral valgus stress, that is going to be for, remember, L आ रहा है, so it won't be LCL. It will be medial collateral ligament. On the other hand, varus test, this is going to be LCL. All right, so varus is LCL. So here, yes, the L will not be there in two places. ठीक है, so this is going to be varus and valgus test. Are all of these tests clear, guys? इसमें से एक ना एक question तो we expect. Okay, so these are all of these things compiled. Going on to nerve injuries. So nerve injuries में हमारा 3 है. हाँ, थोड़ा तो न्यू रहेगा ना. If I keep the same thing, then why would you want to see more classes? So I have to keep updating myself. Basically the thing is I can't teach the same thing again. That is my intrinsic problem. So I have to study something new every time. What is this classification? This is called as Seddon's classification, right? So this is the Seddon's classification. McMurray is also for meniscus. All of those three were for meniscus. So Seddon has classified nerve injury into 3: neuropraxia, axonotmesis, neurotmesis. सबसे best prognosis किसका है? Neuropraxia, where actually you do not have any discontinuity, you just have a nerve conduction issue, isn't it? So Is it reversible? Yes, it is 100% reversible, and it will be a sudden reversal, है ना? आप देखोगे one movement में ये reverse हो गया है. If I do a Tinel sign here, will it be positive or negative? Tinel will be negative, isn't it? Because there is just neuropraxia, there is no discontinuity. Okay, so here it is completely reversible. What about axonotmesis? Yes, this is also reversible, but how will it reverse? It will slowly regenerate. यहाँ पे axon sheath गई है, so yes, there will be progressive reversal, right? So this is called as motor march. This is called as motor march. And will there be Tinels positive? Yes, Tinels is positive, and you will see that every day it is progressing by 1 millimeters, right? So we will see that Tinels is positive, and every day thoda nerve regeneration ho raha hai, and it is progressing. Neurotmesis, on the other hand, this is complete discontinuity. Now there is complete discontinuity. So now will this be reversible? No, this will not be reversible. I will need to treat it surgically, right? So this can only be reversed if I do a surgical repair. Otherwise, this is not reversible, isn't it? Because complete discontinuity hai. Will Tinel be positive? Tinel will be positive because discontinuity hai, but will it progress? No, Tinels now will be static, है ना? तो nerve injury तो है, wherever you have dissection, you will have Tinels positive, but it won't progress, isn't it? So this is what you will need to know about all three of them. Yeah, axonotmesis, everything is, all the layers are done. Okay, so you can do Sunderland's also, but it correlates. Yeah, 1 to 5 of this and 3 of this, you can just correlate. Okay, yeah. So end neuroma pe Tinel positive आएगा, correct. Tinel positive means wherever you tap at the nerve, you will have tingling sensation. So that is Tinel sign. नाम से पता लगता है tingling. Okay, so this is Seddon classification. Right, going on to different nerve injuries and the tests. One question for sure, if not more, one for sure from the next 5 minutes. Okay, so what nerve are we talking about? We are talking about axillary nerve. We are talking about axillary nerve. Static Tinel रहेगा, Tinel positive आएगा, but वो progress नहीं करेगा. Somebody, okay, right. So axillary nerve के causes क्या क्या है? सबसे पहले you will have fracture. ह्यूमरस का प्रॉक्सिमल फ्रैक्चर ह्यूमरस से हो जाएगा, नेक ऑफ ह्यूमरस. देन anterior dislocation of shoulder, most common nerve is axillary nerve. Then if you do deltoid IM injection incorrectly, nerve में घुसा दिया, you can have a problem. And what is this syndrome that I'm showing you here? This is the quadrilateral space, right? So when you have compression at the quadrilateral space, you can have axillary nerve. What are the two contents? One nerve and one vessel. Nerve is obviously axillary nerve. The artery is posterior circumflex humeral artery. Okay, so these are the two contents which can get compressed. So thoda sa anatomy, quadrilateral space syndrome. Signs क्या मिलेंगे? Yes, you will have anesthesia here, which is called as the Reginald Batch sign. So you'll have anesthesia at this side. Apart from that, two muscles. What are the two muscles supplied by axillary nerve? One is going to be, what is responsible for abduction 15 to 90? It is going to be deltoid. So when deltoid is gone, the abduction initiate to ho jayega, because what initiates? Supraspinatus initiates, right? So 0 to 15 degree ho jayega supraspinatus se, but 15 to 90, which was supposed to be done by deltoid, will not be there. And external rotation is done by T minor. So again, axillary nerve supplied by T minor, external rotation nahi ho payega. So this is what we will have in axillary nerve issues. Got it, everybody? Going ahead to the next one. What nerve are we talking about? And then we go into this. Yeah, so the theme here is ulnar nerve palsy. What are the two places where ulnar nerve get compressed? One is at the medial epicondyle, and this tunnel is cubital tunnel. So remember, cubital में U आ रहा है, ulnar nerve. No, just see this, Biswa. No need to do anything previously, just bone tumors, which I have given you already. Okay, and this is the nerve which is here, which is called what? This is the Guyon's canal, isn't it? Guyon's canal is formed by which ligament? This is formed by the pisohamate ligament. Very nice. So this is formed by the pisohamate ligament. You have the ulnar artery, ulnar nerve here. This is the Guyon's canal. So दोनों में ही U आता है. You know that it's ulnar nerve compression. What are the tests? Very important. Before we go into the name of the test, just understand ulnar nerve क्या क्या supply कर रहा है. One, it is going to supply all the interossei, right? So you know pad and dab. Everybody knows pad and dab, that palmar interossei at adduction, dorsal interossei, abduction, isn't it? So ये muscles दोनों ही ulnar supply कर रहे हैं. Then we have the medial lumbricals, isn't it? I have the medial lumbricals supplying by the ulnar nerve. All of my hypothenar muscles, no exception. And what thenar muscle or what thumb muscle is getting supplied? Adduction, right? So adductor pollicis. So this is what you need to have in mind, and then all of these tests become very clear कि ये सारे muscles है ulnar के. तो एक तो medial lumbricals. Lumbricals, all of you know, this is the function where you have flexion at metacarpophalangeal, and here you have extension. So what will I have? I will have a medial claw hand, right? So medial claw hand अगर है तो वो ulnar हो गया. Fine, that we don't want to discuss. What are the other tests? When we do a card test, मैं बंदे को बोल रही हूँ कि कार्ड को पकड़ो, so you will need to do adduction, isn't it? Adduction करना पड़ेगा. So palmar interossea is getting tested. So this is called as card test. When I ask the person that resist, abduct mat karo, resist this. What is this? So we are testing dorsal interossea. This is called as Igawa test, correct? Then I ask the person to hold a book. Normally, we are going to hold the book by, normally I'm going to use adduction, isn't it? Thumbs ko adduct karke rakh rahe. But this person cannot adduct, but book ko फेंक bhi nahi sakte. So what muscle he will use? He will flex. So he is using flexor pollicis, isn't it? So when I see कि book को पकड़ने के लिए adduction नहीं, but flexion use हो रहा है. What sign is this called? This is called as Froment sign, or this can be called as book test, isn't it? So book test or Froment sign is what we are seeing here. And we know all the hypothenar, all the digiti minimi muscles are being used. So digiti minimi एकदम ही lateral चली जाएगी. This is called as Wartenberg sign. This is called as Wartenberg sign, different from Wartenberg syndrome, which we will get to, or Wartenberg test, which we will get to. Okay, so this is Wartenberg sign. Yeah. All right. So is this clear, everybody? So this is card test, Igawa test, Froment, and Wartenberg. These are all signs. ठीक है ulnar nerve के. Thank you. On the other hand, अब theme क्या है? अब हमारा थीम है median nerve, isn't it? So median nerve कहाँ कहाँ पे compress होगा? One, median nerve can get compressed because it passes beneath the two heads of pronator teres. So one is called pronator syndrome, जहाँ पे compress होगा. Then we have one Struthers ligament. एक spur होता है accessory जहाँ पे एक ligament है. So that is another cause, Struthers ligament. Most common that we have already seen the signs for. This is going to be carpal tunnel, isn't it? So now I am showing you an MRI. Can we diagnose carpal tunnel syndrome on ultrasound or MRI? Yes, nowadays we are doing a lot of imaging. Okay, very nice. This is basically the carpal tunnel, and you will see that this is the median nerve. And when I see flattening of median nerve, this is basically the flexor retinaculum, and we see that it is moving and it is compressing the median nerve. I can see this in real time on ultrasound, and we can see it on MRI. So this is the median nerve which is getting compressed here. So this is carpal tunnel syndrome, which is also the cause of median nerve compression. Going on to the test. So everything with a P is gonna come here. Okay, so ape P आता है. So this is called as ape hand, wherein I would find now median में क्या है? All your thenar muscles except adduction, right? So I would see कि adduct हो गया है thumb, and thenar eminence is atrophied. So I would see one adduction because that is supplied by ulnar nerve of the thumb, and I would see that there is atrophy of the thenar eminence. This is ape hand. On the other hand, what is this? Two lumbricals, lateral वाले lumbricals बचे थे. So I will see that one. I can also see claw hand. Apart from that, what I can also see is this. When I ask the person to flex, this person basically, I will see that ये वाली thumbs, fingers flex नहीं हो पा रही, isn't it? So this is called as pointing index, or this is also called as Pope's benediction, or this is also called as one more thing, Osner clasp, है ना? तो everything P, Osner clasp, Pope, pointing, all of these things are signs wherein हमारी fingers flex नहीं हो पा रही when you ask the person to make a fist. Okay. On the other hand, ये क्या है? Claw, different. No, claw is completely opposite. Claw is lumbricals, isn't it? Claw is lumbricals, whereas here what am I doing? I am checking the function of FDP and FDS. That is what I am checking here. Flexion. Claw में क्या हो रहा है? Lumbricals. You will see this. So lumbricals का function क्या है बताओ? Lumbricals का function है ऐसे. कैसे पता चला flex नहीं हो रहा है? Extend. See again. You have to see basically. Claw hand is completely different, ना? तो वो function अलग है. That is gonna be here. You will have hyper extension of metacarpophalangeal and flexion at PIP, DIP. यहाँ पे क्या हो रहा है? Fingers का flexion नहीं हो रहा है, isn't it? बाकी कुछ तो देंगे hint, कुछ देंगे कि fist बनाने को बोला and this is happening. Okay, so these are the 3 tests. बाकी ये बताओ क्या है? This is pen test. So what function am I checking now in pen test? What is the function that we are checking? Abduction, right? So now I'm checking abduction of thumb. I want to see if the thumb is coming and touching the pen. So this is abduction. So this is definitely median nerve का function. This won't happen in a normal person. Last time का question है ये. So nerve injuries में से one question तो sure shot. In AIMS they ask you 2 to 3 questions, right? In one exam only. So very important. समझ में आ रहा है बच्चों? Yes. So that's why I have not just given you names and lists, right? They will ask you images and they'll ask you muscles and concepts. Okay. तो conceptually याद रखो, याद हो जाना चाहिए. What is this? Yeah, so first of all, we'll do this again, but this is supracondylar humerus, and supracondylar humerus, the most common nerve to be injured is AIN, anterior interosseous nerve, which is a branch of median nerve, So this nerve specifically is going to supply the flexor digitorum profundus or flexor pollicis longus. So basically, hamara distal most flexion. So what will happen when I'm making an OK? I want flexion here, isn't it? So I want flexion, which is not going to happen properly. So this is called as OK sign, or also called as what? Also called as kilonavin, also called as wow sign. So okay भी बोल सकते हो, wow. So whatever you want to call it, right? So okay, but basically the technical name is kilonavin sign, wherein this distal most flexion of the digit will not happen. Okay, तो वो wow या okay नहीं बना पाएंगे. Got it? So this is about AIN. Last nerve, सबसे simple nerve is gonna be the radial nerve. Everything extensors are supplied by radial nerve, isn't it? So what are the various causes? We can have crutch, where it can get compressed at the axilla, or it is also called as Saturday night. जब एकदम out okay on Saturday night, you are lying on a limb for the entire night, you will have neuropraxia of radial nerve. What is this fracture? This is called Holstein-Lewis. Again, at the spiral groove, the radial nerve is running. So Holstein-Lewis fracture, a fracture of the spiral groove, will have injury of the radial nerve. Again, this is most commonly neuropraxia only. And finally, two rare things. Very nice. Two rare things where you have a radial recurrent artery. Okay, so radial recurrent artery forms a circular arcade that can compress, that can actually compress the radial nerve. That is called as leash of Henry, arcade of Froche. So just remember these names, okay? What to explain about Holstein? It's a radial groove fracture where radial nerve gets injured, okay? So leash of Henry, arcade of Froche, where you can have radial nerve compression. And what is this fracture? This is Montegia fracture, right? So Montegia fracture, remember, in like specifically which branch of radial nerve gets compressed here? You have PIN, posterior interosseous nerve, which is your exclusive motor nerve, which is getting injured. Okay, so we have to see how to distinguish between PIN and radial nerve. दोनों में ही wrist drop होगा, दोनों में ही finger drop होगा. How do you distinguish? We have to distinguish on the basis of sensory loss. So what part of the hand is exclusive sensory loss for radial nerve? So for this, I want you to remember this symbol. Okay, so tip of little finger is ulnar nerve exclusive. Tip of first finger is median nerve exclusive, and this area that you have here is exclusive radial nerve. So dorsal web space exclusive radial nerve. तो अपने को ये देखना है यहाँ पे. We will see if it is preserved, it is PIN. If it is gone, it is radial nerve. Okay. Leash of Henry and Holstein are different. Leash of Henry और arcade of Froche ना यहाँ पे ये radial recurrent artery से बनता है. Not important. Just remember names. Okay. So they'll ask you कि बताओ कौन सा nerve है? It's radial nerve. Okay, yeah, exclusive area, one more. So see this. This is the confusing diagram. Do we want to remember everything? No. I just want to remember exclusive kya hai, because everywhere else you will have overlap. Montegia, we will go into it again. Don't worry. Okay. So ulnar nerve. So when you see tip of little finger, this is ulnar nerve. When you see this tip of the index finger, this is going to be median nerve. And when you see this area, this is the dorsal web space. This is going to be exclusive radial nerve. Okay. So bas khali itna sa dekho. Fine. Now going on to the treatment. All right, going on to the treatment. When you have a claw hand, it could be a complete claw hand or it could be a partial claw hand. You want to basically now do the normal movement. Lumbricals ka normal movement is flexion at MCP, extension at PIP, DIP. We do this movement in knuckle bender cast. Okay, so this is the knuckle bender class, which is given for claw hand, which could be median nerve or ulnar nerve or both. On the other hand, when you have wrist drop, finger drop, उसी को opposite कर दो, ऊपर करके रखना, extend करके रखना. We use this as cock-up splint, which is used for radial nerve injury. What is this? where you are keeping as an aeroplane. So unilateral aeroplane that we are seeing, this is for either axillary nerve or brachial plexus, है ना. So brachial plexus और axillary के लिए ये use करेंगे. And when you have foot drop is because of CPN, है ना, common peroneal nerve का injury होगा. When you have foot drop, we use this. This is what? This is just toe raising. इसको बोलते हैं toe raising splint. Correct. So this is toe raising splint that you have here. Okay, everybody. So we've done these splints of nerve injuries also. Now let's completely compile all of the causes of nerve injuries. So if you have shoulder dislocation, neck of humerus, what is the injury? Yes, axillary nerve. Holstein-Lewis, spiral groove fracture, it is radial nerve, isn't it? Radial nerve, transient neuropraxia happens. Montegia fracture, we have PIN, the motor branch of radial nerve. Supracondylar, remember the mnemonic AMRU. This is the order. So most common is AIN, followed by median nerve, followed by radial, followed by ulnar. कोई भी हो सकता है. This is the order of involvement. Elbow dislocation, vowels stick together, ulnar nerve. Wrist dislocation, we know wrist पे, carpal tunnel, median nerve. Hip dislocation, what is the nerve to be injured? Most commonly we have posterior hip dislocation. So posterior में most common is sciatic nerve. On the other hand, anterior hip dislocation अगर पूछा, which nerve is going to be femoral, correct. So femoral nerve for anterior hip dislocation. Knee dislocation, you will have popliteal, right? So we will have the, not popliteal, we will have femoral nerve, right? So femoral nerve will get compressed here, okay? Femoral nerve, or when it's divided, CPN at the neck of fibula. So CPN or femoral nerve depending on level. CPN more common. When we go to compression syndromes, at carpal tunnel, we have median nerve. What about pronator, ligament of Struthers? Again, median nerve, right? So all of these spaces will have median nerve getting compressed. Both use cubital and Guyon's canal. We will have ulnar nerve. Arc of Roche, leash of Henry, between supinator muscles, this is going to be radial. Remember, the artery, radial recurrent artery, will form both of these. Wartenberg syndrome, we saw Wartenberg sign was for ulnar nerve जब digiti minimi उड़ रही थी. Wartenberg syndrome is when you have superficial radial nerve. This is the sensory branch of radial nerve, opposite of PIN. Only the sensory part of the radial nerve goes. So this is chiralgia paresthetica. Meralgia paresthetica, on the other hand, is lateral cutaneous nerve of thigh. So how to know, very silly mnemonic again, how not to get confused between meralgia and chiralgia. So chiralgia will remind you of cheeks, है ना. So cheeks को कैसे खींचोगे, किसी के हाथ से खींचोगे, पैर से खींचोगे, हाथ से खींचोगे, right? So हाथ is radial nerve. So you will remember हाथ का superficial radial nerve is chiralgia, meralgia paresthetica is lateral cutaneous nerve of thigh. ठीक है? So this is how you can remember this. Okay, thoracic outlet we've already seen. Which nerves, which nerve roots? C8 and T1 roots. Piriformis syndrome, what is the nerve getting compressed here? This is going to be piriformis. Again, sciatic, isn't it? So sciatic nerve will get compressed here. Tarsal tunnel, it is posterior tibial nerve. Posterior tibial nerve. Morton's neuroma क्या होता है? Morton's neuroma, remember, is a misnomer. It is not a nerve injury. It is fibrosis basically. All right, so it is fibrosis of the interdigital nerve. At what level? At third and fourth metatarsal space, right? So third and fourth metatarsal पे interdigital nerve का fibrosis हो जाता है because of compression. And there is one test which we use, which is the squeeze test. When you squeeze the calf, squeeze the ankle, you will have pain here, which is called as Mulder's sign. Very good, very nice. So Mulder's sign, remember, Morton's neuroma. And quadrangular space, we have already seen axillary nerve and posterior circumflex humeral artery ka compression. Yes, are all of these one-liners sorted, everybody? So we've done nerve injuries, nerve compressions. Now we go on to fractures from head to toe. सारे fractures करेंगे, सारा management करेंगे, everything. Okay. So going on to some one-liners of fractures. So when we talk about healing of fractures, what is the first stage of healing that you will see? Correct. The first stage of fracture healing is going to be hematoma formation. After hematoma formation, we are going to have, so this is going to be for 1 week. Okay. After hematoma formation, I'm going to have inflammatory stage, which is going to be for 2 to 3 weeks. But the first radiological sign of healing is going to be the third step, which is the soft callus formation, right? So this is going to be the soft callus formation, which happens at third week. So at 3 weeks, normally when you get discharged after the fracture, अगर किसी को fracture हुआ है, we call the patient up for an extra 3 weeks. Okay, so that's to see the soft callus formation. Clinical sign of healing कब देखेंगे? So this is going to be at 4 to 6 weeks when you have a hard callus. Okay, when you have a hard callus, it's going to be 4 to 6 weeks. 3, no? First stage, 1 week. Inflammation, second stage. Soft callus, third stage. Fourth stage, hard callus. कुछ याद ही नहीं रखना. Okay, this is very, very easy. Okay, so soft callus, third, hard callus, fourth week. Most common site of non-union, if I ask you. Non-union कैसे define करेंगे, guys? No, it's not scaphoid. It is, yeah. So if the fracture has not fused for more than 9 months, first of all, that is called as non-union. What is the most common side? It's actually the lower half of lower one third of tibia. Nobody has answered it. Lower one third of tibia is the most common side of non-union because there's no muscles, right? There's no movement. There's no muscles. Okay. Yeah, delayed more than 3 months. Most common cause of non-union is what? Most common cause is inadequate immobilization. जब हिलते जा रहे हो, immobilize नहीं करा ठीक से, so inadequate immobilization is what is the most common cause of non-union. So now all of the other fractures you have named, what are all the sites where non-union is seen? Remember the mnemonic flutes. So what is F? Fracture neck of femur, है ना? तो मतलब NF याद रख लो, FN. So femur neck is what you can remember. Then what is L? That you have all told me correctly. Lateral condyle of humerus. Lateral condyle of humerus. U say ulna ka lower one third. T say tibia. This is the most common side. Tibia ka lower one third. And one more with T is gonna be what? That you all told me correctly. It's gonna be talus. And S say scaphoid. So now when you all answered most common site of non-union as scaphoid, that is not correct. But when I ask you scaphoid का most common complication क्या है, then if you say non-union, then I will agree. समझे? So scaphoid most common non-union, and remember we confuse it with AVN, avascular necrosis. That's a specific complication. Most common is non-union. ठीक है, फिर से scaphoid में बात करेंगे, but remember here only. Will you remember flutes, guys, for non-union? What about malunion? Miscellaneous. M. So 3 things where you have malunion. So last है उसी के relation में. I say you will have intertrochanteric femur. S से you will have supracondylar, वहाँ lateral condyle था, यहाँ supracondylar humerus हो गया. C से we have clavicle also and we have scaphoid था वहाँ पे, उसके नीचे colis आ गया, यहाँ पे colis. Okay, so these are all the areas which undergo malunion. Will you remember this, guys? Miscellaneous and flutes, दो mnemonic आते ही होंगे पहले से. Going on to an important classification of open bone fractures, Costello-Anderson classification. Before I go into this, what is going to be the general management of anybody who has open bone fracture? It's going to be debridement and external fixator. Do you all know the external fixator ka image? I did not include it because I thought you know Elizaro's. Yes, do you know Elizaro's external fixator? हाँ, तो उसका image ऐसे निकलता है ना. Just see that if you have not seen. Okay, so this is going to be the general management. Now you want to know the classification here. So type 1, less than 1 centimeter. Type 2, more than 1 centimeter, clean wound. Both of these are clean wounds. Okay. Type 3 is going to be contaminated wound, railway track injury, gunshot, everything is going to be type 3. Type 3 में क्या है further? If you have periosteum which is not intact, periosteal stripping है 3A. If you have soft tissue which is gone, that is 3B. And when you have vascular injury, that is 3C. So in addition for 3B, what do I have to do? Soft tissue को cover करना पड़ेगा. So I need to do additional grafting here. 3C में additional क्या करना पड़ेगा? Open vascular repair. When you have arterial damage, you need to open and you need to do vascular repair. Okay, so this is the management and classification of open bone fractures. ठीक है, fair enough. Just see this, easy है. Okay, going ahead to pediatric, Salter and Harris classification, epiphyseal injuries. So Salter Harris, one example. So it's a very nice trick. Okay, right? So from 1 to 5, Salter से याद रखेंगे. Type 1 is straight across, along the growth plate only, along the physis you have injury. Example of this is gonna be S से ही skiffy, slipped capital femoral epiphysis. So first पूरा S से हो जाएगा. Then we go on to A. A is above. This is the most common type. Type 2 where it's going into the metaphysis. Above में जा रहा है. What is the most common example? This also happens to be most common pediatric fracture. So 2 का हमारा theme है most commons. This is overall most common and the most common pediatric fracture supracondylar humerus. And yes, this is called as Thurston-Holland sign, isn't it? This metaphyseal corner that is formed is Thurston-Holland triangle. Okay. L means नीचे भी जा रहा है, epiphysis में भी जा रहा है. So what is this example? This is seen in tibia, lower end of tibia. It goes into intra-articular tibial fracture. So what is that called? T से ही tibia, T से ही Tillos fracture. Yes, why everybody is so silent? Because you know this all or you don't know. Silent क्यों हो? Usually तो नहीं आता तभी silent होते हो. Tillos आता है, कोई बात नहीं, चलो अभी सीख लो. Writing, all right. But speed is okay, right? Speed is okay, no? ठीक है. So intra-articular tibial fracture, this is gonna be Tillos fracture. Confusing लगता है तो अभी easy, you'll revise this PDF ना, सब सही हो जाएगा, है ना? All is well. What is T? T is पूरा सब कुछ ही जा रहा है. Meta, epi, I mean growth plate and epi, everything is going through and through. So T is through and through. This is gonna be what? This is going to be LCH, right? So this is going to be lateral condylar humerus, है ना? So lateral condylar humerus, quick revision. Tell me, is this malunion or non-union? Miscellaneous and flutes, है ना? तो flutes में ही आ रहा था ये, तो non-union, right? Mal क्यों बोल रहे हो? So you have to remember miscellaneous, no? So miss में तो कोई L है ही नहीं. So it's supracondylar, right? So supracondylar is malunion, and this is non-union. याद रखोगे? Is it volatile? You revise it one more time, it'll be okay, right? And ER is basically any sort of crush injury. गिर गए and सब कुछ growth plate crush हो गया. So this is no example. Okay. I know 2 o'clock, I mean what to do, but it's okay. Good use of non-productive time, I feel. जब non-productive time है, you can just basically remember, study passively. Tillo can't understand. So here you will have injury which is going into epiphysis. It's going into articular surface, growth surface, right? So it's going into the joint, isn't it? So articular पे जा रहा है, joint surface पे जा रहा है. That is Tillo, lower. ठीक है? So this is about Thurston. This is about Salter-Harris classification. Now head to toe, going on to different injuries. Tell me, what is this? So now what is the theme? Yes, we are talking about shoulder dislocation. Is shoulder the most common joint to dislocate? Yes, it's the most common joint to dislocate. Why? Why is it most common? Because of the ratio of the head of femur to the glenoid cavity. Very asymmetrical. What is this ratio? It is 4:1, isn't it? So head is very big and glenoid is very small. So because the ratio is asymmetrical, it's the most common joint to dislocate. Most common type of shoulder dislocation is what? Most common type of shoulder dislocation is this, which is anterior dislocation. Anterior dislocation mein what is the most common subtype? Where the head goes below the coracoid. So this is subcoracoid. So subcoracoid, what you can see here is the most common type. Coracoid process arises from what kind of epiphysis? Atavistic epiphysis, right? So just remember the name. Atavistic epiphysis से arise करता है coracoid process. I'll just write that here. Okay, fine. What is the cause of recurrent anterior shoulder dislocation? Two things we want to remember: Bankard and Hill-Sachs. So when I see that inferior labrum, inferior glenoid labrum is fractured, this is called Hill-Sachs or Bankard's. This is Bankard. So Bankard's correct is the antero-inferior glenoid labrum भी हो सकता है and bone भी हो सकता है. So when you see a bony fracture of the antero-inferior glenoid, that is bony Bankard's. When the glenoid labrum, the cartilage is injured, that is called ligamentous or standard Bankard's. Okay, so here I am seeing bony Bankard's, but I can also have ligamentous Bankard's. Okay, so yes, investigation of choice is MR because I won't see a bony fracture all the time. Correct. On the other hand, if I see posterolateral humeral depression, if I see an impaction fracture on the posterolateral humeral head, what is that called? That is called as Hill-Sachs. Okay, will you remember this? Posterolateral, you can see, no, it's lateral and it's behind. On the other hand, glenoid is anterior and inferior. Okay, so this is about that. And yes, the shoulder view, very nice. The shoulder view that we can actually do to see this is called as strikers, not swimmers. It's called as strikers notch view. On the other hand, swimmer's view is when I extend the arm further, when I want to see cervico-dorsal junction. Spine में जब cervico-dorsal junction देखना है. So swimmer's view is when you want to see cervico-dorsal junction. What is the skyline view? 3 S's. Skyline is for patella, isn't it? Patella को ऐसे ऊपर ऐसा करके view ले रहे हैं. So this is skyline's view. Okay, fine. Going ahead, what is this dislocation? When you see that पूरा humeral head end face दिख रहा है, correct. So this is light bulb sign. So this is light bulb sign that you will have here, and we will also see that the glenohumeral distance is increased. Increased glenohumeral distance, and you will see a light bulb sign, which is basically posterior dislocation. Okay. On the other hand, when you see that the arm is hyper abducted, and the point is, you will have to see that the femoral shaft and the spine of scapula are both in one line. When you see spine of scapula here and you see femoral shaft are both in one line, this is the inferior dislocation. This is the rarest type, luxatio erecta, right? So these are the three types. Mechanism, clinically कैसे patient आएगा? So in anterior dislocation, patient आएगा ऐसे, boundary से ball फेंक के आ रहा था, अचानक से हाथ मुड़ गया. So the patient will be abducted, external, rotated. So here you will have Aber. On the other hand, posterior dislocation, the patient would have had seizures. So adducted internal rotation, opposite, added, adducted internal rotation. Inferior dislocation, ekdami, hyper abducted. Here the patient would be in a lot of pain, hyper abducted arm. Okay, is this clear? Entire topic of shoulder dislocation? Yes. What? How do we treat? How do we treat anterior dislocation of shoulder? So you have one maneuver here, which is called Cocker's maneuver. Yes, which is called team. So team में अपने को क्या करना है? We need to do traction. Basically opposite, adduction or adduction and medial rotation, right? So basically internal rotation, medial rotation is what you want to do. So opposite of the injury जो patient लेके आए उसको opposite कर दो. Just नाम याद रखो, Cocker's maneuver. ठीक है, हाँ, एक घंटा हो गया. All right, anyways, I think we are at good pace. Hopefully we'll finish what we had intended. What do we have here? Fracture proximal humerus. So just tell me two things. What is the classification for this and what is the nerve which is injured here? टेस्ट भी होती है इसकी, टेस्ट इतनी इंपॉर्टेंट नहीं है एंटीरियर शोल्डर डिस्लोकेशन की. टेल मी द नेम्स, जस्ट नेम्स ओनली यू नीड टू रिमेंबर. सो देयर इज Dugaways. So this Dugaways test. No, there's Callaway's, right? There are three. Dugas, correct. So there is Dugas test. I just remember ABCD. So there's Dugas test. There is Callaway's test. There is axillary ruler test, which is Hamilton ruler test, correct. And there is Bryant test, correct. Okay, this I had not revised only. This is Hamilton test. Fine. So these are the ABCD. This is how I had remembered. Okay. So chart test here for axillary anterior shoulder dislocation that you can just remember. Okay. ABCD. Fine. So we have two things about proximal humeral fracture. One is the classification, which is the Neer classification. So I see how many fracture fragments are there, and depending on that, we can have Neer classification 1, 2, 3, 4. Okay, 4 part, 3 part, 2 part. On the other hand, the nerve which is injured that we already saw, axillary nerve. Okay, right. ये है ना, नहीं दिख रहा क्या? ये है ना, पूरा का पूरा हेड निकल गया है. Okay, so it's not subtle at all. Complete head is dislocated. This is proximal neck humerus. Okay, thank you so much. Okay, what do you have here? पूरा क्लास के बीच में detailed feedback you have given me in the middle of the class only. Thank you. What do we have? So we have Holstein Lewis. We have Holstein Lewis class fracture, isn't it? Where you have spiral groove ka fracture, and you will have radial nerve injuries and neuropraxis. This is radial nerve injury. Right? So this is Holstein Lewis. Most common fracture that you see in children. My nephew had this last year when I was at home. My nephew had this fracture, supracondylar humerus. है ना? The supracondylar humerus fracture. So here you have two types of classifications. One, batao, is this flexion type or extension type? So this is called extension type, wherein what do I see? हमेशा हमें देखना है displacement, isn't it? So we have to see displacement of the distal fragment. हमेशा proximal को देख के इन्होंने तो बोलना है तो आगे जा रहा है. It's going behind, right? So there is dorsal displacement of the distal fragment. So this is basically extension type, and they ask you what is the most common displacement. So most common displacement is what? It is dorsal displacement. And kaisa dorsal displacement? Medial or lateral? Medial. So it's actually dorsomedial, which is the most common displacement that you see. है ना? ये देंगे ना image? क्यों नहीं देंगे? यही देंगे और क्या देंगे? Okay, so this is supracondylar humerus, where you have fracture of the supracondylar humerus. है ना? Fishtail is the deformity which will happen, right? So this is not fishtail sign. Fishtail deformity will be seen in distal humeral fractures. Okay. Okay. So now then there is one more classification. One more classification क्या है? One more classification is the Gartland classification that I'm showing you, isn't it? So this is Gartland classification which has type 1, type 2, type 3. Type 1 is undisplaced, minimally displaced fracture है. Dorsomedial समझ नहीं आया, so medial तो इसमें नहीं दिखेगा. Medial we will have to see on AP view, right? Obviously AP will show you medial or lateral. So basically अपने को देखना है ये fracture हुआ तो जो distal fragment है, where is it going? Is it going पीछे या is it going आगे? So we can see with respect to proximal fragment, this is distal, this is dorsal, isn't it? So basically I see that distal is going piche, so that is dorsal, and when I see AP I will also see it goes medial, है ना? So basically this is dorsomedial displacement which is most common. ये याद रखना है. ठीक है, क्या बोल रही थी? हाँ, Gartland. So type 1 is undisplaced. Type 2 क्या है? What is type 2? Don't talk about amidst yourself or other things. पहले इस पे ध्यान दो. Type 2 is when you have partial fracture. Okay, this is partial fracture. And type 3 में क्या है? You have complete fracture of the supracondylar humerus. So type 1, how do you manage? We're just gonna do a conservative management. On the other hand, when you have partial or complete, अब क्या करना है? We need to do a closed reduction with K wires, isn't it? K wires से fix करेंगे. Okay, so this is what we do here. Closed reduction with K wire fixation of the fracture fragments. Very, very important is going to be all of the complications of supracondylar humerus. So what is the nerve injury that is very common? AMRU. Yes, so we have AIN followed by median, followed by radial, followed by ulnar. Okay. What is the type of nerve injury? Always. Anytime they ask you this, is going to be neuropraxia, correct? Which is going to be the most common type of injury. Is malunion going to be seen here or non-union? Malunion, isn't it? So we remember miscellaneous had S, this is malunion. What is the deformity you will have when there is malunion? You can see there is cubitus varus, right? So we can see again varus or valgus कैसे बोलते हैं? Always see distal arm, है ना? तो distal arm is coming inside. So this is called as gun stock, like a shotgun it is. So this is called as gun stock deformity, where you will see a cubitus varus. Vascular injury कौन सा है? एक ही आर्टरी जाता है यहाँ पे. It's brachial plexus. The other complication that we have is compartment syndrome and its 7 P's and its controversies, isn't it? So in 7 P's, 2 questions for you. What is the first symptom that the patient will have, which is also the first P? It's going to be pain. What is the first and the most specific sign that you will have? It's going to be stretch test, right? So there's going to be pain on stretch of the passive stretch of the fingers, which is called as the stretch test. This is the second pain. Then we have few P's in the middle, like what? Like paresthesias, like pallor, like paralysis. And then they will ask you what is the last sign, which is a big controversy, that paralysis hai ya pulselessness hai. It is, just believe me here, it is pulselessness. So just before this class, because it's a controversy, right? Is this a controversy or everybody has agreed ki ye pulselessness hai? Ever when I was also studying, it used to be a controversy. So I asked Apur sir just before the class was starting. I just texted him ki sir paralysis hai ya pulselessness. So sir said pulselessness, so I will just believe whatever he has said, है ना? So that I can quote. ये quote करने के लिए मैंने सर को मैसेज किया कि सर क्या होना चाहिए आंसर. This is pulselessness, मान लो यार. ठीक है, sir knows, like he's been there for a long time. This pulselessness only, just मान लो. And the other complication that we can have is VIC, Volkmann's ischemic contracture. So here image based question आएगा in VIC. So first of all you will see forearm, देखो कितना atrophied है. You will see that there is complete flexion here. कोई बात नहीं यार, ये तो है ही ना कि मैरो ने ये दिया. This is same for Meissner's and Merkel's only. So such things, you just have to follow one source and then you trust it. And it can be marrow also. So marrow को मानने तो वो भी मान लो, but उसको छोड़ दो. If you keep asking 100 people, no, you'll get 100 answers and you will only get more confused. So here, Shraddha, one thing we will remember, Hindi class, huh? You want Hindi? How many demands? Somebody doesn't want Hindi, somebody wants Hindi. Just live with whatever you are getting. Okay, so just believe one thing and you stick to it. Okay, so this is VIC. And what is the caste for VIC? Gujarati also. Huh? Sab seekh leti hu. I will conduct classes in all regional languages of the country. This is turnbuckle. So this is called as Volkmann's ischemic cast also, but who will ask Volkmann's ischemic cast is used in what condition? They will not ask you this, right? So this is turnbuckle cast. Okay, the turnbuckles cast and turnbuckle splint, very nice, is used for turnbuckle splint is and cast is used for scoliosis. Okay. So this turnbuckle cast. But if it is not treated, how will you treat? What surgery is used for Volkmann's ischemic contracture? It is called Max Page. What scoliosis? Now, jaldi jaldi chala gaya. So this is turnbuckle cast. Turnbuckle. No, this is sorry. This is turnbuckle splint. Turnbuckle cast is seen in scoliosis. I will show you. Don't worry. वो दिखाऊंगी. Because this is a splint. This is not a cast. Okay. So this is Max Page surgery, wherein we basically do a distal sliding of the flexors. सारे flexors का एक distal sliding होगा. Okay. So these are all the things of supracondylar humerus. Okay, this is one whole chapter in one slide. Okay, so just revise this. Hand is what sign? There's no sign. इसका कोई नाम भी है क्या? There's no sign. This they can ask you diagnosis बता. This is VIC. Okay, Volkmann's ischemic contracture. Distal slide कर देंगे, खींच लेंगे पीछे flexors को. Okay, another one complication, image-based complication. What is this? Yes, myositis ossificans. So why I have gotten two X-rays? What is the mimic of myositis ossificans? वारस देखेंगे ना, डिस्टल तो देखो, अगर पास आ रहा है तो वारस है, अगर दूर जा रहा है तो वैल्गस है, जैसे मैंने अभी दिखाया. So this is osteosarcoma. So when you see one, there is a cleft which is forming. It's a cleft. So this is parosteal osteosarcoma, surface osteosarcoma. And the other way to distinguish, जब आपको दिख रहा है center is more dense, the whiteness is more in the center, that is osteosarcoma. Myositis ossificans as an O, right? So remember, it will have distal. Distal is more dense than the center. So this is how we will distinguish myositis ossificans from parosteal osteosarcoma. Massage का history होगा, yes, in cases of trauma, या supracondylar humerus का fracture का history होगा, right? So some sort of history will be given here. ठीक है? Okay. Going on to this, what is this? This is lateral condylar humerus, isn't it? So this is LCH. This is a fracture of necessity क्योंकि intra-articular है. So इसका treatment कैसे करेंगे? Because पहले जब पुराने जमाने में you had fracture, you would not undergo like closed reduction K wire, right? आपको वैद्य के पास लेके जाएंगे, who will basically massage की pain हो रहा है, चलो massage कर देते हैं. So then you will have myositis ossificans. इसलिए हाँ, displacement of fracture hematoma से, very good. So this is a fracture of necessity, so you will have ORIF. So remember, all your fractures which involve the articular surface, this is gonna have this is going to need ORIF. On the other hand, when I talk about complication, this is going to be malunion or non-union. Flutes was in non-union, isn't it? So this is non-union. And what is the complication that can occur in non-union? You can have tardy ulnar nerve palsy. Tardy means late. So you'll have tardy ulnar nerve palsy here because of what deformity? Because of, yes, everything opposite. Cubitus valgus है ना, तो L for lateral condylar, L for valgus. ठीक है, ये याद रखेंगे. Good, you remember glim also. Two fracture dislocation complexes. तो यहाँ पे हमारा mnemonic है grimus. When you have inferior radius, inferior means distal radius का fracture है, confuse करना ही नहीं है. Grimus याद रखेंगे, you will never forget. Okay, so when you have, thank you, when you have distal inferior radius है ना, proximal distal भी क्यों confuse होना, inferior radius का fracture है with radio-ulnar dislocation, this is Galazzi. On the other hand, Montegia US, when you see superior ulnar shaft ka fracture, this is gonna be Montegia. Very, very easy. Okay, so I should have kept these like this, but anyways, so this is Galazzi when you have inferior radius, and this is Montegia when you have superior ulna. Bas to grimus yaad rakhoge to life is sorted. In Montegia, superior ulnar shaft fracture and radial head dislocation. Here you have fracture here, and you have this. Okay, will you remember this, guys? Yeah. Do you want to, if this is clear, should I confuse you a bit? What is reverse? What is reverse Galazzi? Montegia. Is it Montegia? What is reverse Montegia? So remember, Galazzi is reverse Montegia, but Montegia is not reverse Galazzi. So Galazzi को हमने reverse Montegia बता दिया. But what is reverse Galazzi? So reverse Galazzi is when instead of radius you have ulna का fracture. Correct. जब यहाँ पे ulna का fracture है, distal ulna, that is RG, reverse Galazzi. Okay. Only if this is sorted. प्लीज गो इन टू रिवर्सेस, अदरवाइज डोंट रिवर्स, जस्ट रिमेंबर ग्रीमस, वरना सब कुछ रिवर्स हो जाएगा. सो ग्रीवस को उल्टा नहीं लाना. ओके एवरीबडी, इज दिस क्लियर? सो गलाजी इज रिवर्स मोंटीजिया, बट रिवर्स गलाजी इज अल्ना का फ्रैक्चर. ठीक है फाइन. सो सब कुछ सिंपल रखो, जस्ट रिमेंबर रिवर्स गलाजी क्या है, अल्ना. तो बचा हुआ तो रिवर्स मोंटीजिया हो गया ना, तो ये याद ही नहीं रखना. ठीक है, मुर्गा मुर्गा कुछ नहीं, ओनली रिमेंबर रिवर्स गलाजी मतलब अल्ना, बाकी कुछ याद ही नहीं रखना. गॉट इट? ठीक है, चलो आगे जाते हैं इनटू अदर फोर आर्म फ्रैक्चर्स. व्हेन यू हैव यूनिकॉर्टिकल बेंडिंग, कॉनकेवो कॉन्वेक्स बेंड है और यूनिकॉर्टिकल, दिस इज पीडियाट्रिक फ्रैक्चर. दिस इज व्हाट, बच्चे बच्चे ग्रीन होते हैं, ग्रीन स्टिक फ्रैक्चर. ओके, ऑन दी अदर हैंड पूरा का पूरा फ्रैक्चर ऑफ शाफ्ट ऑफ अल्ना रात में बिकॉज ऑफ डिफेंस इंजरी जो होता है, दिस इज नाइट स्टिक, है ना, लाठी चार्ज से जो होता है, स्टिक से जो होता है, दिस इज नाइट स्टिक फ्रैक्चर. एंड व्हेन यू डोंट हैव कॉर्टिकल डिसकंटिन्यूटी, यू जस्ट हैव अ बल्ज, you have bend, this is torus fracture. Okay, so this is torus और करेक्ट बक्कल फ्रैक्चर. ठीक है, क्योंकि रेडियस है ना अर्जुन, दिस इज रेडियस. नो, why would this be reverse galazi? ये तो रेडियस है. Torus, can you see this bending of the bone? The cortex is intact, but the cortex is just bent, it is not torn. Okay, so this is about that. बताओ ये in the slide with 3 pick, ये because there is no dislocation ना अर्जुन. For Montegia Galazi we also need radio ulnar dislocation. तो ऐसे तो फिर कोई भी अल्ना का गलाजी हो गया, ऐसे नहीं ना. ठीक है, right. Now what is this intraarticular? So this is distal end of radius fracture. Tell me, distal end of radius fracture, intraarticular, extraarticular? What do you see in this image? One, I see it is extraarticular. So now when I see extraarticular, I need to see two things. Is the fracture fragment getting displaced dorsally, or is the fracture fragment getting displaced anteriorly? So how do I say that? Just a second. All right. So when we have extra-articular fracture, how extra-articular? Because it is not reaching the joint surface, right? We can see that this is radius and this is extra-articular, right? So it's not reaching the joint surface. I'll show you intra-articular also. So here it is like this, no? The fracture line is horizontal. It's not reaching the articular surface. Okay, let me show you so that you do not confuse it. When I see this fracture, can you see this? Can you see this fracture, AP and lateral? So AP, can you see how it's reaching here till the joint surface? So this is articular. Can you see how it's reaching the joint surface? So this is intra-articular. Is this clear, everybody? Because this is the most basic thing. You cannot get Coley's and Barton's wrong, right? So here I am seeing that this is not reaching. It's going to be horizontal. It will never reach like this. It will always be like this. Got it? So सबसे पहले देखना है AP में whether it's reaching the joint surface or not. So इससे अपने को समझ आ गया कि ये इंट्रा या एक्स्ट्रा. अब कंफ्यूजन होता है एंटीरियर पोस्टीरियर. वेरी इजी, थंब को देखो, थंब इज ऑलवेज गोना बी एंटीरियर. सो व्हेन द डिस्टल फ्रैगमेंट इज गोइंग पीछे, थंब यहाँ है, फ्रैगमेंट डिस्टल जा रहा है पीछे, दिस इज गोना बी कोलीज. थंब आगे है, फ्रैक्चर फ्रैगमेंट डिस्टल जा रहा है आगे, कोलीज. अंडरस्टूड? सो स्मिथ, सो पीछे जा रहा है, दिस इज गोना बी कोलीज, एंड आगे जा रहा है, इट्स गोना बी रिवर्स कोलीज और स्मिथ. ठीक है, तो इसके लिए हम याद रखेंगे डी सी, or yeah, C and D go together, so you just remember CD. So Colles is going to be dorsal displacement. What is the deformity that will happen in Colles? Very nice, Arnav, that's amazing actually, सब कुछ है उसमें. Yeah, so in Colles I'm going to have dinner fork deformity. तो इससे भी CD से याद हो जाएगा, dinner fork deformity. Smith fracture, what is the deformity that you will have? गार्डन स्पेड, है ना. तो S फॉर स्मिथ, S फॉर स्पेड, गार्डन स्पेड डिफॉर्मिटी. दोनों का ही मैकेनिज्म ऑफ एक्शन इज व्हाट? दोनों का ही मैकेनिज्म ऑफ एक्शन इज फुश, फॉल ऑन आउटस्ट्रेच्ड हैंड. सो इन फुश, इफ द पर्सन सेज दैट आई लैंडेड ऑन माय डोर्सीफ्लेक्स्ड रिस्ट, डोर्सीफ्लेक्स्ड रिस्ट पे लैंड किया, तो दैट इज कोलीज. On the other hand, if you've landed, fall on outstretched hand and the hand is palmar flexed hand पे land किया, it is Smith. So remember this would be mentioned because our instinct is the moment I hear osteoporotic postmenopausal female who is going into fall on outstretched hand, I will straight away think of Colles. You have to read it. Palmar flexed है तो it will become Smith. Okay. ऑसिफिकेशन, ऑसिफिकेशन बाद में बताती हूँ, आई ऑल्सो हैव टू रिवाइज, कुछ गलत ना बता दूं. ओके, सो आई टेल यू इन द नेक्स्ट क्लास. सो कोलीज एंड स्मिथ, वो ने जो अलग होमवर्क नहीं किया क्या अर्जुन? यू हैव नॉट डन होमवर्क, अदरवाइज यू वुड हैव नोन. दिस इज कोलीज एंड स्मिथ. फाइन, I have also not done homework. This is push. Fine. Chalo. Abhi intra-articular. What else that I want to tell you? Yeah, in Colles, what is the most common complication? If they ask you most common complication of Colles, डोंट टेल मी माल यूनियन. एक तो माल यूनियन क्या कोलीज में होता है, बट इज इट मोस्ट कॉमन? नो, इट इज नॉट मोस्ट कॉमन. करेक्ट, मोस्ट कॉमन इज फिंगर स्टिफनेस. अपार्ट फ्रॉम दैट कोलीज में नॉन यूनियन होता है, माल यूनियन होता है, like I just said, malunion, right? The third complication, if they tell you that there is tenderness, there is osteopenia on the X-ray, periarticular osteopenia, a lot of pain in the hand, what is the diagnosis? That is called as Sudex dystrophy, right? So that is called as Sudex osteodystrophy, wherein you will have sympathetic over injury, overstimulation, and you will have a lot of pain. Okay, so these are three complications of Colles. Going into the कास्ट के बारे में एंड में बताती हूँ. ओके, कोलीज एंड स्मिथ, गॉट इट. नाउ द फ्रैक्चर इज इंट्रा-आर्टिकुलर. इज दैट प्रॉब्लम सॉल्व फॉर एवरीबडी? विल यू रिकॉग्नाइज इंट्रा-आर्टिकुलर? या, सो रिमेंबर, इंट्रा, when you want to drink a ton of alcohol, you have to go inside the bar. So that is how you will remember Barton. Barton bar ke andar ton of alcohol, it has to be intra. You have to go inside the bar, right? So this is intra-articular Barton's fracture. Again, Barton's can be volar Barton's or dorsal Barton. So ये बताओ कौन सा Barton है, volar है या फिर dorsal है? कैसे एक्स्ट्रा आर्टिकुलर लग रहा है? देखो ये जा रहा है ना यहाँ पे, इट्स गोइंग. नो, सी एक्स्ट्रा मतलब ऐसा होगा. कैन यू सी दिस गोइंग लाइक दिस, राइट? सो इट इज गोइंग इनटू द जॉइंट सरफेस. ये तो इंट्रा ही है. यस, कैन यू सी नाउ? या, सो दिस इज वोलार. अब वोलार और डॉर्सल का भी क्लियर हो गया. सो दिस इज थंब एंड वी आर सीइंग कि यहाँ पे आ गया है. सो दिस इज वोलार बटन. या, दिस इज एक्सरे ओनली. नो, हाँ, दिस इज एक्सरे ओनली. ऐसे डाउट क्यों पूछ रहे हो? So this is X-ray, right? So this is going to be, फिर मुझे लगता है कि ये सब छोड़ के रेडियोलॉजी पढ़ाने लग जाओ. Okay, so this is volar Barton. Fine, so this is Barton. Is this clear, everybody? इंट्रा एक्स्ट्रा समझ नहीं आया तो उसके लिए अपने को देखना है फ्रैक्चर लाइन. इज इट गोइंग इन द जॉइंट सरफेस? सी, नो, हियर इट इज, दिस इज लाइक दिस. ऑन द अदर हैंड कोली स्मिथ में कैसा था? कोली स्मिथ में इट इज हॉरिजॉन्टल, इट्स नॉट रीचिंग द जॉइंट सरफेस. देखो ऐसे ही है, यहीं पे, लाइक दिस. अंडरस्टूड? ओके, चलो अभी आगे बढ़ते हैं. यस, वी नीड टू प्रोसीड, अदर वी वोंट बी एबल टू कंप्लीट, गाइस. ओके, Sabrine has what doubt? Kohli, see, thumb, you have to see relation of distal fragment with thumb. All right, if we have to consider thumb as anterior, if the fracture fragment is moving in the direction of thumb, it is anterior. If the fracture fragment is going posterior and the thumb is aage, thumb is anterior, this is Kohli's reverse. Understood, everybody, please? Yeah. All right, so this is Kohli, Smith and Barton. And when you have just the radial styloid fracture, what is this? Radial styloid, this is Schoffer's fracture. This is Schoffer's fracture. Another thing, remember, so Schoffer's also is intra-articular. Do you agree that Schoffer's fracture bhi to intra-articular hi hai? Yeah, or is there any doubt? Is this reaching joint surface? For sure, it's reaching the joint surface. So Barton's versus Schoffer kaise karoge? So that is technically done on the lateral view. Okay, so what you have to see on the lateral view, that this is the radial surface, and what is this? This is the scaphoid, right? So this is a scaphoid that you can see here. So if you see that the relation between this teacup, not just the scaphoid, also the lunate, you can see how the dislocation is happening. There is no relation between the teacup and the radial head. So scapholunate jab dislocation ho raha hai, you have to remember not just scapholunate, radiolunate. So when you see that the lunate and radial head are not maintained, that is going to be seen in Barton's. But when that relationship is maintained, that is going to be seen in Schoffer's. Okay, will you remember that? So nobody will ask you in detail mein, but just that is the difference. That is how we say. This is not the spilled tea or coffee per se, but here also you are not having this relation which is maintained. When there is no fracture, but फिर relation नहीं maintain हो रहा, that is dislocation. That is lunate dislocation or perilunate dislocation. Okay, understood, everybody? Yeah, so let me just repeat that part again. So what will happen if there is no fracture? यहाँ तो fracture है इसलिए dislocation हो गया, isn't it? But if you have no fracture here and you see that this cup is spilled, this is not maintained in the radial head, that is lunate dislocation, which is the spilled cup sign. So now cup can have coffee or tea, your choice. So spilled tea cup or coffee cup sign, that is basically when the lunate is not maintained. But when this relation between radius and lunate is maintained and the scaphoid basically goes away, that is called as perilunate dislocation. Which is more common? It's going to be perilunate, which is far more common. Okay, understood? So this is about that also. Fine. जाए आगे. Okay. What about this? The fracture which is very commonly missed on an AP view of the wrist. So a lot of times I need to do an oblique view of the wrist. So this is going to be scaphoid fracture. So this is scaphoid fracture. We can pick it up on oblique. Even then also it is missed a lot of times. So this is something which is best picked up on NCCT. Okay. So scaphoid, remember, is the most common carpal bone to be injured. What is the other problem with scaphoid? This has retrograde blood supply, right? And the part which is injured commonly is the waist of scaphoid. Waist is most commonly injured here. So the specific complication because of the retrograde blood supply is going to be AVN. So AVN is specific, but what is the most common complication if asked of scaphoid? Where did this come? Yeah, so this is going to be non-union, remember. So this is क्योंकि S दोनों में आ रहा है, it comes in flutes and it comes in miss. So remember, do not mix it up. Miss का S is supracondylar humerus. This is flutes का S. Okay, so this is going to be non-union. Okay, so non-union is the most common complication of scaphoid. ठीक है, understood? Yeah. So now doing all the casts together. So two things which are very commonly confused. One is this and one is this. Can you tell me क्या है? कौन सा क्या है? So this is like shaking a hand, isn't it? So here you are shaking your hand. So कैसे याद रखना है? Look at the thumb. When you see the thumb is free, this is hand shaking. Have you met people who will shake hand and they will move their thumb like this? Okay, so that is my mnemonic. कि कुछ लोग हाथ मिलाते हुए thumb को ऐसे ऐसे खेलेंगे, right? So that is how you can remember that when the thumb is free while shaking hand, some people will move their thumb. So this is hand shaking cast. Hand shaking cast किसके लिए है? The fracture which you must have heard. For exam, you cannot go without knowing this fracture. That is Kohli's. Okay, so now people who don't know Hindi, I'm sure you know Shah Rukh Khan at least. Everybody in the world knows Shah Rukh Khan, isn't it? So you know Rahul, Shah Rukh Khan says Rahul, नाम तो सुना ही होगा. वैसे ही we say that fracture Kohli's नाम तो सुना ही होगा. नाम तो सुना होगा means you must have heard the name, right? So we need to remember Shah Rukh Khan here. So handshaking, Shah Rukh will be like Rahul, नाम तो सुना ही होगा. So handshaking cast, Kohli's. One more fact, why Shah Rukh Khan came into picture. So Shah Rukh Khan is from UP, isn't it? So what is the position of this caste? ये पूछते हैं. So UP is going to be ulnar deviation, pronation and palmar flexion. अब इसका भी सीक्वेंस पूछा है तो that Marrow only knows. Okay, that I don't know. इतना काफी है. That now you only decide sequence because that is too much now. है ना, ये तो ज्यादा ही हो गया. Ulnar deviation, pronation and palmar flexion. You need to draw a line somewhere. You can't just do any question. Okay, तो एक बार कर लो. Sequence I don't know. You see sequence and post on the group. है ना, एक बार sequence देख लेना. अब पूछा है तो पता चले यही क्वेश्चन आ गया. So ulnar deviation, pronation and palmar flexion. Fine. So this is about handshaking and Kohli's. Fine. I can really feel your FOMO basically because you always have that feeling ना कि जो नहीं आता था पता चले वही पूछ लिया. That way you can't leave anything basically because then you have that intrinsic fear as medico कि अरे यही आ गया तो, right? So that's why you can't leave anything. That's why do things which are needed. If you see something very unusual, then you would want to basically learn that, है ना? तो ऐसी चीजों में जाना ही नहीं. This is previous year question. Sequence is not previous year question. What is the caste position is previous year questions. Okay. Fine. So this is handshaking. On the other hand, when you are holding a glass, where is this seen? So this is seen in scaphoid. So again, the story behind this is scaphoid fracture is something that is easily missed, isn't it? That's the fact that we know. Now, a doctor, an orthopedic surgeon who has missed the injury at night is very sad. So he would want to hold a glass with whiskey, isn't it? So he is holding a glass. So glass holding. And he's a doctor who's holding the glass. So we remember DR here. So what is the position here? The dorsiflexion and radial deviation. Or you can just remember UP and opposite of that is scaphoid. Fine, everybody. तो ये हो गया. अब बताओ ये क्या है? बस अभी फिर से शुरू मत हो जाओ. This marrow bitching starts anytime something happens. Okay, so this is, and मेरी क्लास में ही होता है. You are gonna get me sued for some reason, and you guys are doing it, and I will get sued. The cylindrical cast. Okay, so cylindrical cast, and what you are having, this will be seen in patella. Okay, so this is seen in patella, and for patella, you have to do skyline view. Okay, you have to do skyline view. Fine. What is this that you are seeing here? Do it in private telegram group, don't do it as a public class mein. This is hanging u slab hai na. This is hanging u slab of humerus. This is seen in humeral fractures. What about this very complex looking cast, isn't it? So this is also seen very complex injury, which is acromioclavicular dislocation, where you will have Wellpau's bandage. Okay, so this is Wellpau's bandage. And ये क्या है? 8 बन रहा है. So this is figure of 8 for clavicle. Okay, everybody, are all of these casts done? Yeah, we also do Zanka's view. Amazing. So we do Zanka's view for acromioclavicular joint. Okay, so थोड़ा सा untidy हो गया, just manage. Zanka's and Wellpau's. ठीक है? Fine. Going into thumb, this is taking a lot of time. In thumb, what do we have? So now we have to see fracture. Oh, all of these are fracture dislocations. So both of these are intra-articular, isn't it? Reaching the joint surface of carpometacarpal joint. Now here you have to see how many parts. Correct. So bay in Gujarati means two, है ना? You know Gujarati, इतना तो पता होगा. Bay, right? So bay is two, right? So two-part fracture. So this is Bennett fracture, where you will have two parts here. Okay, where you will have two parts. The AC not working. On the other hand, when you have three parts, can you see how there's a comminuted fracture, three parts? So this is Rolando. So Bennett Ronaldo, base of the thumb. Three part is Ronaldo, two is Bennett's. And what is this? Fracture neck of the fifth metacarpal. This is कोई बात नहीं, ये बताओ. This is boxers. So fifth metacarpal का neck. This is boxers. Okay, so these are the three fractures of the hand. So this is Bennett and Ronaldo, two parts. Bennett, three parts. Rolando. Okay. Then what is this? What is this here? Bennett versus pseudo Bennett is this only. Pseudo Bennett will be extra articular. When you see कि ऐसा fracture, it's not reaching the intra-articular surface, that is pseudo Bennett's. Okay. Yeah, so this is the skier's thumb. This person is skiing, no? So skiing के time पे injury हुआ of the thumb. So what is going to be the injury here? You have an avulsion fracture of ulnar collateral ligament. So what all do you need to know about this? This is the skier's thumb. What happens here? There is avulsion. Fragment होगा, avulsion fracture होगा of ulnar collateral ligament. Okay, ulnar collateral ligament. Now with ulnar collateral ligament, you have to be reminded of ulnar nerve. Can you tell me which was the only thenar muscle that was getting supplied by the ulnar nerve? Yeah, also called as gamekeeper's thumb. What is skier's thumb, gamekeeper's thumb, same. Yes, adductor pollicis. Remember? So here what happens? You can have adductor pollicis which gets trapped. So you have adductor pollicis muscle which can actually get trapped here in this ulnar collateral ligament. And when it gets trapped, that is called as Steiner lesion. And when you have this entrapment, this is an indication of surgery. Understood? So this is the train of thought. Skier's thumb, ulnar collateral ligament. If the adductor pollicis gets trapped, that is called Steiner lesion, which is an indication of surgery. All right. So this is about skier's thumb. Two more avulsion fractures, very important. So when you have extensor tendon ka injury, E mallet. So this is mallet finger, where E for extensor tendon, extensor distal tendon gets in, extensor digitorum profundus gets injured, and you will have fixed flexion. सब कुछ extend हो रहा है, ये नहीं हो पा रहा. So this is extensor tendon injury. On the other hand, when you have, what is this ladki playing? This is rugby, right? So this is rugby or jersey finger. In rugby or jersey finger, what will you have? FDP ka injury. So when you have FDP ka injury, what will happen? You can't flex. Everything is flexing. Here the flexor tendon is not working. Okay. So this is what we need to remember here. One more thing, mallet is also called as bush fracture. This is something new which I read. This is bush fracture, also called as bush fracture. ठीक है, आएगा ट्रिगर आएगा, रुको तो सही. मैलेट एंड रग्बी, सो दीज आर इंजरीज. ट्रिगर फिंगर में पुल्ली का इंजरी होगा, वहां पे आएंगे. स्वॉन नेक में भी आएंगे, रुको. तो मैलेट एंड रग्बी कराई दूं अभी. सो ट्रिगर फिंगर में क्या होगा? ट्रिगर फिंगर में आगे आएगा वैसे इन द नेक्स्ट क्लास. ट्रिगर फिंगर में वी विल हैव एन इंजरी ऑफ द A2 pulley where you will have a fixed flexion. All right, so there the flexion is at both. You will have a fixed flexion at the PIP and the DIP दोनों का. A1 pulley, I'll just see. All right, so pulley का basically injury होता है. A1 pulley, I think, not A2, correct. A1 pulley का injury है. So that's why you will have a fixed flexion deformity here, and you will also have a nodular swelling. Tenosynovitis is also different. That is why wait, no, ये सारे एक साथ ही बता दूंगी. All the other fingers will come, but they are not basically related with trauma. So tenosynovitis, swan neck, everything is not related to trauma. So we'll get to it. अभी खाली मैलेट और रग्बी को याद रखो. E for extensor tendon injury, रग्बी for flexor tendon. We'll get to this. A1 पुली पे भी आएंगे, so just hold on. इसके बाद में ही करेंगे. What is this that you have here when you see wrist का swelling? Yeah, so this is Madelung's deformity. This is Madelung deformity. Can you tell me a syndrome where this is associated? This is associated with Turner syndrome, and the problem here is with the distal radiocarpal joint. Predominantly, there's a physis defect with the radial physis. Remember, so the radial physis is abnormal, and which aspect of radial physis? Ulnar aspect. So do not mix it up. It's the ulnar medial aspect of radial physis. Okay, so you can just remember radial physis की growth का abnormality. There is a triangular radiocarpal junction, and this is Madelung's deformity. Poland कहाँ से आया? Poland syndrome different, where you will have pectoralis का absence. Okay, so Madelung कर ही रहे तो साथ में confuser क्या होता है? Where you have a calcaneal spur. This is the Haglund's deformity. So this is Haglund's deformity, wherein you have calcaneal spur. And because of this calcaneal spur, you're going to have bursitis. So you're going to have bursitis here, and you're going to have the Achilles tendon ka tear. You're going to have Achilles tendon chronic tear. Okay, so all of this triad is called as Haglund's deformity, and this is something which is basically seen in people who wear very high heels, है ना? So high heels पहनते हैं, उनमें Haglund deformity हो जाता है. Fine. Remember that Madelung में deformity था in radial physis also. Radial का growth plate में injury है, radius के distal growth plate पे. What am I showing you here, guys? Image based question. Yes, this is called as TBW. This is called as tension band wiring. And in tension band wiring, what are we actually doing in tension band wiring? We are converting the traction forces into compressive forces, है ना? That is what we are doing. So T से ही याद रखो कि जो traction वाले forces हैं, इनको हम compressive में बदल रहे हैं, isn't it? That is what we are doing. Traction और distractive, जो भी distractive forces हैं, उनको compressive में बंद कर रहे हैं. And tension band wiring is done for two fractures. What two? Patella and olecranon. All right, so patella and olecranon, two छोटे bones, we will be doing tension band wiring. Okay, fine. What about other named fractures? फटाफट से नाम. This we had done in forensic also. One person is standing और गाड़ी मार गई, जिससे हमें पता भी लगेगा the type of vehicle, height and make and everything. What was this? Yes, bumper लगेगा ना गाड़ी का. This bumper fracture. Bumper fracture will be lateral tibial plateau or medial tibial plateau. Very logical, right? गाड़ी अंदर से तो आएगी नहीं, बाहर से ही आएगी. It's going to be lateral tibial plateau, right? So it's going to be lateral tibial plateau, isn't it? So that's why fibula lateral. What is this? When you have calcaneum ka fracture here, this is called as Lever's fracture. So calcaneal fracture, you have Lever's fracture. It's also called as Don Juan. All right, so also called as Don Juan, who must be the first lover who had jumped, जिसके नाम पे हमने नाम रख दिया calcaneum fracture का, right? So this is calcaneum fracture. Here we have two angles, correct? So we have the Bohler's angle and we have the Gisand's angle. So tell me what happens to what? So Bohler's lowers, that is the mnemonic. So Bohler's reduces, Gisand's increasing. So Bohler lower, ऐसे करके याद रखो, ठीक है? Gisand बढ़ जाएगा automatic. What about this? When you have bimalleolar fracture, medial and lateral, so छोटा नाम bimalleolar POTS. When you have trimalleolar fracture, बड़ा नाम तीन cottons. Okay. Dashboard and bumper same. No. Dashboard is different. No. Dashboard will be posterior dislocation of hip. You forgot forensic. When you are standing in ऐसे होएगा तो that is bumper fracture. That is tibial fracture. Dashboard is where what will happen to driver. उसका तो posterior dislocation of hip होगा, right? Where the dashboard hits. ठीक है? So this is POTS and this is cottons. Okay. What is this? Where you have lateral condyle ka fracture, it's a coronal fracture. Remember, coronal plane ka fracture hai. This is the lateral, this is the lateral condylar fracture. This is called Hoffa's fracture. This is Hoffa's fracture, which is your lateral humeral condyle. Okay, sorry, lateral femoral condyle. Okay, what is this? If I'll tell you which child हमने करा है ना, that we have already done, but still I'll repeat. What is this? When you have intra-articular tibial fracture, this is Pilon's. This is Pilon's fracture, and if you see कि it's because of intra-articular avulsion. Avulsion हो रहा है and there is growth plate injury, then it will be what? Salter-Harris. Then it will be telos. It will be telos if you see that there is growth plate injury as well. So then it will be Salter-Harris. Okay. Otherwise, intra-articular tibial is Pilon's fracture. What is this? Talus का fracture हो रहा है. Gonna be aviator fracture. It's gonna be aviator fracture, which is the neck of talus. Again, what is the complication? T के साथ flutes. So this is gonna be non-union, right? So are you guys following all of the flutes and miss? What is this fracture called? When I have distal fibular fracture, distal fibular fracture hota hai, so what do we call? Call it runner's fracture, isn't it? So that's called runner's fracture. ठीक है, very nice. Aviator समझ नहीं आ रहा? So all right. क्यों समझ नहीं आ रहा? Because हमारे anatomy. What is this bone? This bone is calcaneum. Calcaneum articulates with talus. Can you see one break in talus? Yeah. What is this bone? Talus and navicular. Okay, so this is navicular. Tilo, remember Salter-Harris में करा था. So when you have a lower, when it goes from growth plate to नीचे, that is Tillo's fracture. But when you have a complete intra-articular fracture, that is called Pilon's fracture. Okay, so these are all the things that you have. Hawkins sign is subtalar arthritis which can develop. Correct in this. Okay. Now what do you see here? Now there is fracture dislocation. So do you see again anatomy? Calcaneum, talus, navicular. So we can see that here in the intertarsal joint there is dislocation. है ना, tarsal के बीच में dislocation हो गया between calcaneocuboid, talonavicular. This is called चौपाट. Again the mnemonic was थोड़ा हिंदी mnemonic. So हिंदी में भी से ना बीच चौराहे में dislocation, right? So बीच चौराहे means center only. So intertarsal. So this is going to be intertarsal, चौपाट, between the tarsal. On the other hand, when you see very subtle like a French, something that you can easily miss, so very, very subtle, you know, so French people are very subtle in what they say. This is going to be tarso-metatarsal. You see a very subtle dislocation. This is a tarso-metatarsal. This is Lis franc. So remember French, very subtle. Okay, so this is how we can remember these two dislocations. Okay, very, very important, Jones and pseudo Jones. So in this x-ray, what are you seeing? Is this Jones or is this pseudo Jones? So fifth, metatarsal, correct. When I see extra articular, is this extra articular? Now are you guys understanding? क्या बता दो मैम? Are you seeing extra? First of all, intra and extra समझ में आ गया ना? अगर ऐसे जा रहा है तो intra, ऐसे जा रहा है तो extra. So now this is extra articular. So this is true Jones fracture. On the other hand, अगर यहाँ पे fracture मिलेगा, that will be a stress fracture. जिसको बोलते हैं March fracture, isn't it? When it is intra-articular, avulsion हो रहा है ऐसे, this will be your pseudo Jones fracture, which is an avulsion fracture of which muscle? Peroneus brevis. Okay, so that is the avulsion of peroneus brevis. Very, very important. So you can have stress fracture, you can have Jones, and you can have pseudo Jones. Is this clear, everybody? So this is about Jones. Quickly, with 10 minutes remaining, going into spine fractures. So what is this? When you have compression and then you have retropulsion of a fracture fragment. This is called as burst fracture. So this is burst fracture. The buzzword is retropulsion. On the other hand, when you see आगे से पीछे तक, through and through 3-column injury, what is this? This is called as chance fracture, and the mechanism is called distraction. Spine पूरा खुल रहा है. So this is called as chance fracture. Few things about chance. First of all, this is hyperflexion distraction injury. Pura spine is getting distracted. How distraction? This is associated with seat belt injury. Remember seat belt injury forensic, we had done one of this. So with seat belt, very nice. Now we have mesenteric injury, we have pancreatic injury, we have chance fracture. Everything has a poor prognosis. So what will happen? You're wearing a seat belt with car accident. Your upper body will move like this. So you will have hyperflexion. Upper body is moving ahead, rest of the spine is as it is. So the entire spine opens up through and through. So this is hyperflexion distraction. Three columns. What are the three columns that we have? Dennis's columns theory. Dennis ने क्या बोला? If this is the vertebra, anterior 1/3 is going to be first column, posterior 2/3 is going to be second column, and posterior element is going to be the third column. So any two columns are affected, that is unstable, right? So more than or equal to 2 is unstable injury. तो ये तो डेनिस ने बड़ा ही बेसिक क्लासिफिकेशन दिया था that we do not use anymore. Okay, so this is anyways an unstable fracture and it requires surgery. So this is the burst is two columns, right? So the posterior element is not involved, so you are only having complete vertebra and retroperitoneal. So this is a two column fracture. Okay, so chance is poorer than burst fracture. Okay, got it? Spine का समझ में आ गया? What about cervical spine trauma? What do we have here? When a complete burst, four aspect, you are having 1, 2, 3, 4. This is Jefferson's burst. This will occur in divers. है ना? आप उल्टा छलांग मार रहे हो, going उल्टा. This is Jefferson's fracture of. This is a burst fracture, which is again seen because of axial loading. The mechanism is axial loading, but you are diving in head first. On the other hand, when you are jumping, पैर पे jump कर रहे हो. So what are the fractures? So lovers fracture एक तो हो सकता है, which is your calcaneal fracture. Then what else can get injured? Then you can have sacrum fracture, isn't it? So sacrum fracture को और क्या नाम देते हैं? It's also called as jumper's fracture, isn't it? That's why it's called jumper's fracture. So this is about बंदे जो गिर रहे हैं. Okay, fine. What is this? Hanging, right? So remember hanging also we had discussed. So this is hangman's fracture. Fine. Hangman's fracture बहुत सारे नाम है. What to do? But सब कुछ है. इसमें जितना डिस्कस किया उससे आगे तो मुझे नहीं मिला कुछ. Fine. So this is C2, C3 listhesis. Fine. So you have C2, C3 spondylolysis, pars interarticularis का fracture, and then you have listhesis. So this is gonna be C2, C3 subluxation because of pars interarticularis fracture. इसका mechanism जिप्मर जब था तब पूछा था, which was axial loading and hyper extension. Very nice. And hyper extension. So that is the mechanism of hangman's fracture. कर लिया ना spine का? What else do you want? And what is this? Where we have C7 का posterior spinous process का fracture. This is what? This is clay Chevelers. So this is clay Chevelers with spinous process. Very very stable fracture. Okay, एक ही fracture है. अच्छा, एंडरसन डी अलांजो अभी आएगा शायद, एक क्लासिफिकेशन का एक चार्ट है. एंडरसन डी अलांजो इज समथिंग दैट इज यूज्ड फॉर C2, राइट? C2 का फ्रैक्चर का एंडरसन डी अलांजो है. यू वांट टू गेट इनटू द डिटेल्स. सो अगर खाली ऊपर का ही पार्ट फ्रैक्चर है, दैट इज टाइप 1, दैट इज टाइप 1 एंडरसन डी अलांजो. अगर नेक और बॉडी, डेंस के नेक और बॉडी में है तो 2, एंड व्हेन इट पासेस थ्रू द बॉडी ऑफ C2, दैट इज टाइप 3. तो इसमें ना पूछते हैं कि सबसे खराब कौन है. सो टाइप 2 इज द मोस्ट अनस्टेबल. सो 1 व्हेन यू हैव टिप ऑफ डेंस प्रोसेस, दैट इज टाइप 1. व्हेन यू हैव अ junction of dense in body, that is type 2, and type 3 is through the body, that is 3. So these are the C2 or odontoid का fracture का classification है Anderson D. Alonzo. Okay, so this is for odontoid fracture. Fine. आगे जाते हैं. Yes, carrot stick is Satya hyperextension. Baki usually it's all hyperflexion. It's only Angst-Pond ka carrot stick which is because of hyperextension. Wait, we'll go into it. एक के बाद एक जाते हैं. थोड़ा थोड़ा शांति. वही ज़्यादा हो जाएगा. So this is Jefferson, this is Hangman's, this is clay Chevelers. Okay. बाकी Anderson De Alonzo odontoid हो गया. ये बताओ and then whatever questions you have I will take. ऐसे ही बता दो. पोल नहीं करना. Is this anterior dislocation or posterior dislocation? The most common dislocation, dashboard injury. So this is posterior dislocation, and we know that most common is sciatic nerve. So two dislocation of hip, when you see कि ऊपर चला गया है, this is the dashboard injury, posterior dislocation of hip. The person will assume a position of fadir, right? So fadir is the position that you will have when the person is having this. Apart from this, where else can you have fadir? You can have fadir in TB hip. ओके, सो टीबी हिप में फैडिड होगा और पोस्टीरियर डिस्लोकेशन हिप में फैडिड होगा. इन एंटीरियर डिस्लोकेशन बताती हूँ अर्जुन, जस्ट वेट. Faber you will have with anterior dislocation of hip, whereas you will have this with transient synovitis and septic arthritis of hip. ये भी मैं पढ़ाऊंगी अभी. And we have this with iliotibial band contracture, right? So these are three places where I will have this. Okay. No. Jefferson is C1. No, Jefferson is C1. Pars interarticularis थोड़ी है C1 में. C1 is ring fracture. No, right? So this is Fader and this is Faber. Okay. Now, what do you see? How do you diagnose? So, posterior dislocation, dashboard injury, you will see that the femur is going up. So, clinically, what will you see? Limb shortening or lengthening? Upar chala gaya na pair. So, my pen is also giving up. So, here I will have limb shortening. Pen is not working only, guys. You guys are asking too many doubts. पेन चलना बंद हो गया. This shortening. Okay. On the other hand, Faber में क्या हो रहा है? ये नीचे आ गया. So this is gonna be lengthening, right? So here I am gonna have lengthening. Okay, lengthening. ठीक है. Charge तो होता ही नहीं इसमें. There's no charge. This is how it works. What else do we want to know? We also want to see the position of lesser trochanter. So when the lesser trochanter is coming in view, there's going to be anterior dislocation. When LT is hidden, it's going to be posterior dislocation. Most common nerve to be injured in posterior is sciatic. Most common nerve to be injured in anterior is femoral nerve. ठीक है, तो ये हो गया स्पाइन का. Two more fractures associated with ligamentous injury. TS and SA is transient synovitis, septic arthritis. Why I have written short form? Because this we will revisit. We will look at it in the next class. Okay. Here, can you see that there is one avulsion fracture here near the lateral aspect? Fibula के पास एक avulsion fracture है. Very nice. This is called as Sigon's fracture, where you have a lateral capsular ligament avulsion. Why it is important? Lateral capsular ligament has no izzat. It's not very important. But this is an indirectly associated injury, very highly associated with ACL injury. Right? So ACL injury has to be ruled out by MRI in Sigon fracture. On the other hand, when you see medial aspect, superior aspect of medial side, you have this fracture fragment. This is called as Pellegrini Steda lesion. And Pellegrini Steda lesion is something which is associated with medial collateral ligament. इसमें कोई indirect नहीं है, directly only associated with medial collateral ligament avulsion. Okay, so this is about that. So these are all your classifications that you were asking for. After that, I'll basically will be done, I think. Okay, so tell me, Judet and Letournel are used for acetabular fracture, right? So this is something that we use for, how will I write? Acetabulum fracture. Young and Burgess and Tile is used for pelvis. Pelvis ka classification hai. Yes, we do Judet, we also in acetabulum. Very nice. Dennis is used for jumper's fracture. Sacrum, hai na? So this is used for sacrum fracture. Dennis ho gaya. Sanders is used for calcaneum, right? So this is used for calcaneum fracture. Schatzger classification is used for tibial plateau, right? So tibial plateau fractures. Knee, we already know, proximal humerus. How many parts and axillary nerve injury was associated. Gartland classification is used for, yes, supracondylar humerus. 1, 2, and 3 undisplaced, partially displaced, completely displaced. Bedo classification we did not do. Montegia. Most common nerve injured in Montegia क्या था? PIN, है ना? Pure motor nerve. We will have pure motor, no dorsal. Then Frickman classification is used for Colles, right? Colles most common was finger stiffness. Apart from that, Colles will have malunion or non-union. Miscellaneous, right? So malunion, miss. So Colles will have malunion, and what else in Colles we had learned? Ek aur cheez, right? One more thing in Colles. What is the deformity? D, dinner fork deformity. And apart from that, we can also have handshaking cast. नाम तो सुना ही होगा, UP. Pipkin, Garden and Powell, NOF, neck of femur fracture. Evans, NOF से थोड़ा सा नीचे, intertrochanteric femur fracture, जिसके ट्रीटमेंट में हम यूज करेंगे डायनामिक हिप स्क्रूज. Dennis and Weber are basically used for ankle fracture. All right. So for ankle, we also have these Ottawa rules of when we do basically X-ray, when to do X-ray in cases of ankle injury, because ankle injury में bony injury is more common या फिर ligamentous injury? It's gonna be ligamentous injury, and most common ligamentous injury जो I have had in my MBBS years of partying, I used to have one ATFL tear of every 6 months. I used to have one ATFL injury recurrent. Is there any ATFL victim here in the group? Because it's very common. The anterior talofibular ligament, है ना? Tibia, is it tibia or tallo? Oh my god, it's talofibular, isn't it? Just read. Okay, so anterior tallo, है ना? Talofibular ligament. So ATFL tear बोलते हैं, yeah, it's because of injury, है ना? होता है ना बार बार. So it's because of any time you're dancing or you skip a step, basically you will have this injury. It's recurrent. एक बार गया फिर जिंदगी भर जाता है. So this is in the medial aspect, right? So it's going to be in the medial aspect of the foot. Okay, and Kuvada classification we've already done. Thomas test or Thompson test? Achilles tendon tear. This is going to be Thompson, है ना? Thomas was the video that we had seen. Okay, so I think we can stop here at this point. तो ये हमने सारा कर लिया. Spine में remember, it's always going to be hyperflexion. What is going on? There's going to be the pen is now resistant. There's always going to be hyperflexion that we are going to see. Hyperextension injury is only seen when you have a fixed spine, a rigid fused spine, which is seen in cases of Angstborn. So usually it's going to be hyperflexion. Next class के शुरू में बताती हूँ, because now I think it's giving up. Extension is only going to be in Angstborn, है ना? It's only going to be Angstborn. बाकी सारों में hyperflexion. तो hyperflexion with axial loading. अगर आपके वेट से सीधा सीधा गिर रहे हो, लाइक बर्स्ट फ्रैक्चर, जेफरसन फ्रैक्चर, और यू नो ऑल ऑफ दीज, यू विल हैव एक्सियल लोडिंग. ठीक है, इसको बोलते हैं एक्सियल लोडिंग. अपने वेट पे सीधा सीधा गिर गए. सो दिस इज गोना बी द एग्जांपल, इज गोना बी जेफरसन फ्रैक्चर एंड द बर्स्ट फ्रैक्चर दैट वी हैड सीन. ऑन द अदर हैंड, अगर डिस्ट्रैक्शन हो रहा है, स्पाइन खुल रहा है, वी कॉल दैट चांस फ्रैक्चर. ओके, these are the only things that you want to remember as far as the mechanism goes. बाकी कुछ खास important नहीं है. They had asked this thing, hangmans, which we have already done. Okay, so axial loading plus hyperextension, that's just something which is very rare. Okay, तो बस खाली इतना सा याद रख लो. बर्स्ट फ्रैक्चर कब दिखता है? बर्स्ट फ्रैक्चर दिखता है व्हेन यू आर फॉलिंग, एक्सियल लोडिंग, है ना? तो व्हेन यू आर फॉलिंग डाउन, डाइवर्स में दिखता है. डाइव करा और पूल में सीधा सर गिर गया. सो व्हाट यू विल हैव अ बर्स्ट फ्रैक्चर ऑफ द C1. ठीक है, एनीथिंग एल्स दैट यू वांट टू आस्क? Faber and Federer we will revisit once we do transient synovitis and SNO, we will say. ठीक है, बहुत मजा आया, मुझे भी बहुत मजा आया. Okay, so we'll meet in 1 more hour, है ना? 2 hours हो गए, काफी कुछ हो गया. So I think we've covered bulk of ortho. Now we'll be doing rest of things. So we'll do cast and splints. We'll start off with that, and then peds, ortho और बाकी सब कुछ. हाँ, next I'll send you. Okay, all right. Thank you so much, and see you all soon. Bye bye.